Okay,
All right.
Megan, go ahead and take her away.
Good
Please
morning,
introduce yourself.
everybody. My name is Megan. I am the nurse practitioner for the Stroke and Neuroscience program here at Long Beach Medical Center. I know we've got a few different locations here with us this morning, and we're happy to be back doing stroke education. Yay. Happy to see your faces this morning. Please bear with us as this method of instruction is new to us. So if you see me kind of, stopping for a second, doing something on the computer, I'm currently trying to figure out where to put your faces so that I can see my notes. So just bear with us, and we will move through this complications of stroke section first. As you can imagine, this is quite a bit of information. This is going to be the first day, and I am kind of just going to touch on things in not too much depth, just for the sake of time. If you do have questions, if you wouldn't mind holding them for the end, and then we can write them down, and then we'll discuss them towards the end. I just want to make sure that I get through all of the information here, since we do have time constraints. Okay, so our discussion topics today and our goals. We're going to just discuss acute and chronic complications of the various strokes. We're talking about ischemic stroke and the hemorrhagic strokes, which also includes subarachnoid hemorrhage. We're going to discuss the treatments of stroke complications. We're going to discuss complications of stroke interventions, kind of a bit of a tongue twister. And then we're also going to discuss some of the non-neurologic complications of stroke as well. Okay, so first off, we're going to talk about complications of ischemic stroke. We will do a little bit of basic background review of ischemic stroke, just to kind of get your brains warmed up and ready to talk about the complications. So ischemic stroke overview. We've got a picture here of the blood vessels of the brain, the vasculature. With ischemic stroke, an area of the brain is not perfused with blood, which causes lack of oxygenation, and with continued lack of oxygenation, subsequent cell injury and or death. Ischemic stroke is the number 5 cause of death in the country, but the number 1 cause of disability. And here in the hospital, our focus is on early treatment and intervention to prevent disability in the long run. That is our goal. So the different etiologies of ischemic stroke, we can have a thrombosis, which is occlusion, a vascular occlusion secondary to narrowing or atherosclerotic disease. Of course, we can have an embolic stroke, which is a blood clot or plaque originating from another part of the body that travels to the brain and causes an occlusion in the blood vessel. There's also arterial dissection, where blood is not perfusing appropriately to the brain because of the dissection. I wanted to talk a little bit, and just very briefly, about watershed strokes, more so because you may see this in notes. Doctors mention, watershed strokes. So this is more of a systemic hypoperfusion. So if you have a patient with low blood pressure, and you have atherosclerotic disease in the brain, you can imagine those areas are not going to get perfused beyond those atherosclerotic regions. So I like to talk about plumbing a lot when I teach stroke and when I teach my patients. So if you figure that there's some sort of blockage, that area beyond it, when the pressure is low, is not going to get perfused well, and that can cause injury. We talk a lot about large vessel occlusions and small vessel occlusions. Can you see my mouse moving around here? Yes, okay. So large vessel occlusions are going to include more of our large vessels, the internal carotids, middle cerebral arteries, the anterior cerebral arteries, basilar artery, and our posterior cerebral arteries. Those are the large vessel occlusions. And then the smaller vessel occlusions are the lenticulostriate arteries, which originate off the anterior portion of the circle of Lewis. And those affect more of like the basal ganglia, thalamus, and some of the subcortical structures. Risk factors for ischemic stroke, kind of our triad of a lot of our chronic diseases: hypertension, dyslipidemia, type 2 diabetes, smoking, and then of course AFib, and then, you know, hypercoagulable states such as cancer, and other things that cause our blood to be hypercoagulable. So our acute ischemic stroke treatments, I wanted to touch on this. Most of you probably know, but TPA is kind of our go-to. Of course, I'm not going to go into too much detail about when to give it, when not to give it. Like I said, for the sake of time, but TPA is our clot buster. Okay. And then new medication that is coming out is tenecteplase, or TNK. Here at Long Beach Medical Center, we are not using this yet. Hopefully we will in the future. It's a great drug, shows a lot of promising benefit, and it is a single dose medication as opposed to TPA, which is the bolus dose followed by the infusion. We also have mechanical thrombectomy, which we'll talk about here in a minute. Balloon angioplasty and stenting, and that's so ICAD, intracranial atherosclerotic disease. It's a fancy way of saying you've got some narrowing in your blood vessels. Just like you can do this in the heart, you can do it in any vessel, more so proximal, large vessel arteries, internal carotids, MCA, but angioplasty and stenting for atherosclerotic disease to open up those blood vessels. Our other interventions would be, of course, permissive hypertension. We'll get into that a little bit more, but it depends. The blood pressure is going to depend on what kind of treatments have taken place. You're going to do IV fluids and volume repletion. And then, of course, our medications are antithrombotics, our aspirin and Plavix, statins, anticoagulants, lifestyle modification, treating blood sugar, all of those good things. Okay. So mechanical thrombectomy, here at Long Beach Medical Center, we do quite a few mechanical thrombectomies per year. I don't know the exact number, but we go, so with mechanical thrombectomy, I put a picture up here. Hopefully you can see, it's a little bit blurry. We enter through an arterial source, usually the groin, femoral, and then feed a wire up into the brain to pull out the blood clot, which is, if you haven't seen this procedure before, it is pretty incredible. Here at our facility, a lot of times we use the aspiration up here, and then we also use the stent retriever. And then there is also the option of intraarterial thrombolysis, or TPA. We do that occasionally, not often, but that is a possibility as well. And after mechanical thrombectomy, an important thing to know, especially as the nurse, is what your TP score is, because this is going to help you to know where you want your blood pressure to be and how successful the thrombectomy was. So the lower the score, the less reperfusion was obtained with the procedure. So you can see grade 0 is no or minimal perfusion. 1 is penetration, 2A, 2B, and 2C. We do have some reperfusion with different percentages. 2C is near complete reperfusion, except some slow flow. And grade 3 is full perfusion. Okay, so you can see here in these pictures, here is a pre-thrombectomy and then post-thrombectomy. So you can see that vasculature that's opened up here after pulling out that blood clot. It's pretty incredible. And then here is an MRI showing the actual stroke, DWI over here. So the lower your TP score, the more permissively hypertensive you want to be. I'm not going to go into exact blood pressure parameters, because I think it really depends on the patient and what, you know, what the doctors want. So I think the best thing to do is to ask what where the blood pressure should be. Don't let them leave without giving you blood pressure parameters for your patient. And then, like I said, higher, more permissive hypertension, the lower the number, and we're going to be more towards normotensive, the higher the number, to prevent reperfusion injury. Okay. Moving along. So the first complication of ischemic stroke, recurrent ischemia. So in this situation, you may see worsening of their current stroke symptoms. So maybe their blood pressure is too low. Maybe they're reoccluded. Maybe they're dry. So in this situation, you may see some fluctuation in their neuro assessment and exam. Like I mentioned, low blood pressure. Patients that have intracranial atherosclerotic disease, chronic disease, this is what you want to be on the lookout for, because again, if we're not perfusing the area of the stroke because of low blood pressure, we want to make sure that we're giving volume to perfuse. So another situation that you could have is a new stroke. You want to be careful with your patients that have AFib. A lot of patients on AFib in the hospital, with AFib, they may be here and they may need their anticoagulants held for a specific reason. With that being said, if you do have a patient who has AFib and anticoagulation is being held, be on the lookout for new stroke symptoms. You could have a completely new stroke in a different vascular distribution. So our interventions here, of course, would be our frequent neuromonitoring and our NIH stroke scale. You're going to do that as ordered, depending on what area you're in. Q4 hours is usually the least frequent that we're looking at it. Of course, we're going to report changes promptly, right? Just because they had a stroke and they're maybe having worsening of the stroke or new stroke symptoms, it doesn't mean that they're not a candidate for any type of intervention. We want to get some more imaging, right? You want to ask your physician, what kind of imaging do they want? Do they just want a non-contrast CT head? Do they actually want to do full stroke imaging panel, including angiogram or angio and perfusion studies? Or maybe they just want to check an MRI brain to see if the stroke has actually extended or gotten larger. Mechanical thrombectomy could be a possibility. Obviously, TPA is not going to be a possibility if there has been a recent stroke. Okay. In patients that have intracranial atherosclerotic disease, they may be able to stent. Okay, keep that area open. These patients, you need to watch their blood pressure closely. If they are having recrudescence of stroke, you may want to back up on the blood pressure a bit, allow more permissive hypertension. You may want to lay them flat as tolerated, of course. IV fluids. And then when you are adding blood pressure medications, if you're, say on day 3, 4, and you're trying to get that blood pressure down a little bit, you want to be very careful when you're adding those blood pressure medications in patients that may have intracranial atherosclerotic disease. And then, of course, our antithrombotics and anticoagulants as ordered per, appropriately for which patients you're dealing with. Okay. Our next complication is hemorrhagic transformation. I've got some pictures here for you. So hemorrhagic transformation occurs with when there's extravasation of blood from the damaged blood vessels. In a stroke, the blood-brain barrier, chemical cascade of different things happens, which can damage the blood-brain barrier. It makes blood vessels more sensitive to extravasation of blood. In patients that have a very large stroke, or the larger the stroke bed size, the higher the risk of hemorrhagic transformation. Of course, with hemorrhagic transformation, we worry about increased intracranial pressure and mass effect. We also talk about symptomatic versus non-symptomatic, and that's kind of why I picked these pictures. Obviously, you can see here, this is a very large stroke here, looks like MCA. You can see a little bit of hemorrhagic transformation here. This one may be what we call a non-symptomatic hemorrhagic transformation, meaning that it didn't cause an increase of at least 4 points on the NIH. In this picture, I would suspect that this probably caused an increase of NIH greater than 4. You can see there's a pretty substantial amount of blood here. What are we looking for when we are worried about hemorrhagic transformation? Obviously, we're watching level of consciousness. Any depression in level of consciousness could indicate increased intracranial pressure. You may be seeing some worsening of their current symptoms. And then obviously, as it gets worse, you know, looking at pupillary changes and things like that. So our interventions here, of course, imaging to confirm if there's any hemorrhagic transformation. These patients, depending on the size, may need ICU care. If there is any type of coagulopathy involved, we want to reverse those. So we want to look at, you know, our clotting factors, platelets, strict blood pressure control, usually less than 140. We may need to institute cardine, labetalol, things like that to manage the blood pressure. Head of bed elevated, decreasing intracranial pressure. Obviously, we're holding our blood thinners. And depending on the severity of this, you know, surgical interventions, which would be decompressive craniectomy, hematoma removal, and possibly an EVD if we're worried about hydrocephalus or if there's bleeding into the ventricles. Cerebral edema. So if we have a stroke that's a large infarct size, we're really worried about cerebral edema. If a patient goes for thrombectomy and the thrombectomy unfortunately isn't as successful as hoped, you would worry about this. If the patient was not able to receive TPA, they were out of the time window for this, we would be worried about cerebral edema. You've probably heard or mentioned malignant cerebral edema or malignant MCA syndrome, and that is when there was likely no treatment in an MCA infarct, and we have a very large hemispheric stroke with a large stroke bed. Usually, like I said, large vessel occlusions, we're talking proximal MCA and ICAs. With the cerebral edema, we have mass effect and increased intracranial pressure. And again, what we're looking for here with our assessment, decreased level of consciousness, the pupillary changes, changes in motor response, which can be unilateral, and as it progresses, you may see just more of a generalized response as the severity of the cerebral edema increases. And then also herniation syndromes, which we'll talk about here in a second. What are our interventions here? Imaging, of course, always first. Probably going to do a CT head. They may want to do an MRI to look at things a little bit more in depth. We're going to institute our hyperosmolar therapies. I meant to change this, but HTS is my shortened way of saying hypertonic saline or 3% infusion, okay, and mannitol, right? A big thing here, and this is something that I try to work on here at our facility, we want to avoid hypotonic fluids and dextrose-containing fluids. This worsens outcomes. Hypotonic fluids can cause fluid shifts and increase cerebral edema, okay? So we want to avoid half NS, B5W. Those are the ones that can cause faster shifts of fluid and it worsen intracranial pressure and cerebral edema. We want to have as close to normothermia as possible, normal glycemia, so we're watching our blood sugar. We want to know what our sodium goals are. If we're on 3% or hypertonic saline, you know, we want to be higher, hypernatremic. We're going to monitor CO2 and O2. Hypercapnia or increased CO2, we worry about vasodilation and subsequent increase in ICP. Our blood pressure goals, again, this is going to be based on what intervention they've had so far. Okay. We want to avoid hypertension to make sure that we perfuse, but we may not want to go completely permissively hypertensive because we want to be mindful of avoiding hemorrhagic transformation. A lot of times with these malignant cerebral edema, we're going to hold the blood thinners for the first few days at least to avoid hemorrhagic transformation, but also if there is a need for surgical intervention, we don't want to have to reverse any of the medications if we can avoid that. Surgical interventions would be a decompressive craniectomy. Okay. Unfortunately, a lot of times with these malignant MCA syndromes, outcomes are relatively poor. So goals of care is also something that we want to talk about early on, palliative care and supportive care for the patient and their families. Okay, so I have a picture here of cerebral edema, not necessarily from stroke, but you can see here, I've got a normal brain and an edematous brain. And you can see here we've got CSF, we can see the sulci, we can see gray-white differentiation, we can see the ventricles. And when you move over here to this really tight brain, you lose all of that anatomical differentiation, right? It's very smushed, my very technical description, a smushed brain. You can kind of see it here in this picture. Again, there is less space here in between the brain and the dura skull. You can see some of the compression of the ventricles and herniation, which we'll talk about here in a second. Okay. I'm not going to go terribly in depth here for the sake of time, but cerebral edema will eventually, if untreated, will eventually most likely result in herniation. Okay. Herniation is an emergency. That is the main thing we want to get across here. There's different types of herniation, depending on the location of the injury and which direction it's pushing up, down, across. So herniation essentially is when brain tissue is pushed into a compartment of the brain where it's not supposed to be. We'll talk a bit about compliance and Monroe-Kelly doctrine here in a few minutes. But essentially, when you have this rigid skull, increased cerebral edema, we don't have a lot of space to work with. Okay. So with these herniation syndromes, you're going to see changes in a level of consciousness, pupil changes, and then you may see some autonomic changes as we progress, which would be changes with respiratory patterns, Cheyne-Stokes, apnea, changes with blood pressure and heart rate, and this is as we progress through herniation. Our acute interventions are again osmotic therapy, hypertonic saline mannitol, and hemicraniectomy. If you see, if you get the depressed change of level of consciousness, pupil changes, and progression of neurologic deficits, motor changes, cerebrating, diploic posture, and things like that. Okay. I wanted to talk a little bit about hydrocephalus and ischemic stroke because I think this is something that we think more of with bleeding, but hydrocephalus can occur with ischemic stroke as well. So I put a picture up here. So when we're talking about a cerebellar stroke, right? Cerebellum is in the posterior caudal, I guess, portion of the brain. A lot of the nurses here on the fourth floor, we call it the butt of the brain. So you can see how closely it lines up here with the fourth ventricle. So if you can imagine, if you have an infarct in the cerebellum and subsequent mass effect, this could potentially, as you see here, obstruct the fourth ventricle and cause hydrocephalus. Okay. With this exam, you may see headache, nausea, vomiting, vision changes, and then again, depressed level of consciousness. Interventions here obviously are imaging. CSF diversion if needed, but surgical intervention, they may do a preanie for this patient as well to offset the pressure. Okay. Complications of ischemic stroke, seizures. All right. So seizures happen more frequently in hemorrhagic stroke, but they do happen with ischemic stroke as well in about 10% of patients. More common in cortical strokes, okay? Temporal lobe is especially high risk for seizures. So essentially here, we're gonna monitor for seizure-like activity. Just know that that's a possibility. If you see something suspicious, you wanna report it. If you do treat, we wanna try to not over-sedate so we can try to maintain our neuro exam. EEG or continuous EEG. And then we want to monitor for side effects of some of our anti-epileptic medication, phenytoin, we see bradycardia, and then of course sedation. Okay, so complications of some of our ischemic stroke treatments. First, we're going to talk about TPA. The two main complications here, we're going to talk about our angioedema and hemorrhagic transformation. So you can see here, this lady looks quite swollen. People who potentially run a risk of TPA, angioedema associated with TPA, may have ACE inhibitor sensitivity or allergy. So just take caution when your patients have an ACE inhibitor or allergy. Our treatment is going to be to stop the TPA infusion, give antihistamine, steroids, and epinephrine. And then, of course, you're going to monitor the airway. Okay. TPA complication, hemorrhagic transformation. If you have acute changes in NIH, decreased level of consciousness, you want to be mindful that this could be a hemorrhagic transformation. You're going to stop the TPA infusion. We're going to get a stat CT head, and then we are going to reverse the TPA. So we do have a post-TPA hemorrhage order set. This is what is on the order set, but cryo is usually what we're going to be giving here. Also, we do have an angioedema order set as well, just to bring that to your knowledge. And then complications of mechanical thrombectomy. So post-preperfusion hemorrhage is kind of the big one that we're worried about. When you return blood flow to the blood vessels that have been damaged, again, blood-brain barrier changes, you can potentially cause extravasation of blood. We're looking at a same-sided headache, opposite side deficits, and then also be mindful there may be seizures. Blood pressure management, neuro assessments, and early recognition. Okay, and this is why we do CT heads immediately following our thrombectomies. Another situation would be a reocclusion. This usually occurs within the first 48 hours. So again, monitoring your neuro assessments and reporting anything as soon as you see changes. Arterial dissection. Potentially when they're doing the thrombectomy, they can cause damage to the lumen of the blood vessel. Usually here, they may coil if it's severe, but usually it's blood pressure management and close monitoring. We also want to monitor for access site complications, which include hematoma, retroperitoneal hemorrhage, arterial thrombosis, and pseudoaneurysm. We do have the post-TPA and thrombectomy order set, which we have the instructions for monitoring the groin site, as well as the angiography post-procedure order set. Okay. All right, moving along, complications of hemorrhagic stroke. For purposes of this talk today, we are talking about spontaneous hemorrhagic stroke. So we're not talking about trauma and other methods of or etiology behind bleeding, spontaneous hemorrhagic bleeding here. So little overview here. This is the second most common cause of stroke behind ischemic. We can have bleeding into the intraparenchymal space, the intraventricular space, and the subarachnoid space, which we'll talk about a little bit more. ICH or hemorrhagic stroke accounts for more morbidity and mortality than ischemic stroke, which accounts for more disability. Here with this hemorrhagic stroke, we have bleeding into the brain tissue. Okay. Some of the causes are hypertensive angiopathy. Most of our bleeds, I would say, that I see here are related to hypertensive angiopathy. Chronic damage to the blood vessels from high blood pressure. Also cerebral amyloid angiopathy. CAA is closely linked to Alzheimer's, and these beta amyloid plaques can be deposited in the arteries and arterioles, which make it increase the risk for bleeding. Also vascular malformations. Some of the other factors are age, older age, history of previous stroke, some of our lifestyle choices, alcohol, stimulant drugs, tobacco, sedentary lifestyle, obesity, and then of course, anticoagulant use. So I've got some pictures here of an intraparenchymal hemorrhage, and then we've got an intraparenchymal hemorrhage with intraventricular involvement as well. Okay, briefly, ICH score. This is something that is usually calculated by the provider. It's a prognostication tool. I just want to give you a brief introduction to it so that when you see it, you know what it means, okay? So basically this is a 30-day mortality, what's the word I'm looking for? It's a predictor of 30-day mortality and functional outcomes. So we're looking at the Glasgow Coma Scale on admission. We're looking at the volume of the ICH. Is there presence of intraventricular hemorrhage? Where is the location of the ICH? And then what's the age of the patient? And then you can see here that the lower the number, the less 30-day mortality, and the higher number, the worse 30-day mortality and worse outcomes. Okay, so I said we would talk about the Monro-Kelly doctrine. This doesn't just apply to hemorrhagic stroke. It can apply to any situation where we do have increased intracranial pressure. But essentially, we have our skull, which is the rigid compartment that holds our brain. And then our intracranial components, we've got 80% of the inside of our skull is the brain. We've got 10% blood and 10% CSF. When there is an increase in one of these components, it causes compliance of the other components. And because we don't have much room, or really any room, we don't have many places for that to go. So it can cause damage inside the brain to the brain tissue. Increased ICP can eventually result in herniation if not treated, again, which I mentioned earlier. Okay. So a complication of hemorrhagic stroke, increased intracranial pressure. This can happen by a few different mechanisms. We've got the initial space occupying lesion, right? We've got a bleeding into the brain, and that is going to cause increased intracranial pressure because it's taking up space. Our secondary injury can be expansion of that blood. We've got the mass effect and edema surrounding that injury, which can essentially then cause ischemic injury, and then hydrocephalus, which I put twice. So again, hematoma expansion plus edema equals mass effect and subsequent increase in intracranial pressure. I've got here a picture of kind of all the different places that they can put drainage systems, but here we go is our EVD or extraventricular drainage system. Here with hemorrhagic stroke, increased intracranial pressure causes reduced perfusion, which can result in ischemic injury. Of course, a very large intracranial bleed can cause herniation. Again, symptoms, which this seems to be kind of the most common one here. We're looking at changes in level of consciousness. We're looking at changes with your pupils. Cushing's triad, we're looking at our vital signs and our autonomic regulation. You may see changes with blood pressure, hypertension, bradycardia and changes with respirations. And then herniation syndromes. So imaging for evaluating ICP. We're going to look at CT head. It's going to show us anatomical structures to see if what level of increased intracranial pressure we're dealing with. They may want to do a CTA to see if there's any sort of vascular abnormalities that contributed to this hemorrhagic stroke. We're going to check our coags, CBC platelets, sodium. Our big interventions here are going to be blood pressure control. Usually we want the systolic less than 140. We want to avoid hypotension because, again, we want to make sure we're perfusing the brain. If there are coagulopathies, we want to reverse those. We've got a great number of medications now that actually reverse coagulopathies. Back when I used to work in ICU, we only had blood products. But now we've got Kcentra for Coumadin, we've got vitamin K, which goes with the Kcentra, and for Xarelto and Eliquis. We're also going to be looking at osmotic therapies like our hypertonic saline, 3% mannitol. Seizure prophylaxis. Okay, we want to avoid seizure activity in these patients because that is going to worsen outcomes. Our surgical interventions, extraventricular drainage placement and CSF diversion. If we're worried about hydrocephalus, we may be doing a decompressive craniectomy. Depending on the location of the bleed, they may do a hematoma evacuation. And most of the time, this is on when you have injury on the non-dominant side, depending on the location of the bleed. If it's a deeper bleed, that's obviously more difficult to reach. So it's patient specific, and it also kind of depends on age and potential outcomes. Our interventions here for increased intracranial pressure will be elevated head of bed, maintaining head and neck alignment. We want to make sure that the venous outflow is open to decrease the ICP. We want to monitor our CO2 and oxygen levels again, increase CO2 and hypercapnia can increase intracranial pressure. We're going to monitor sodium levels. Our goals here are euvolemia. We want to have normothermia or as close to normothermia as possible. And we want to watch our blood sugar. Again, we want to avoid our hypotonic and dextrose containing fluids, as those will worsen increased intracranial pressure, and frequent neural checks. Some of our last ditch efforts, or what I call Hail Marys, are hyperventilation, which can temporarily increase intracranial pressure, neuromuscular blockade, and pharmacologic coma. Those are some of our last ditch efforts to try to treat increased intracranial pressure. Again, with hemorrhagic stroke, hydrocephalus is a risk. Just like we talked about ischemic stroke and hydrocephalus, if you do have bleeding into the cerebellum, we're also worried about fourth ventricle obstruction. With intraventricular hemorrhage, we worry about obstruction as well and hydrocephalus because of the blood products blocking reabsorption. In a thalamic hemorrhage, we're worried about the third ventricle compression. So anytime you've got bleeding in the brain, you worry about hydrocephalus. Obviously, we're going to see this with CT head. Treatment of this would be CSF diversion with a extraventricular drainage system, possibly surgical decompression, and then institute our ICP lowering treatments. Seizures, again, I mentioned this is more common with hemorrhagic strokes. Early seizures are more associated with neurochemical changes, whereas later seizures are more as a result of structural changes as a result of the damage to the brain. We want to get on top of these quickly and add our antiepileptic medications. So monitor for your seizure activity. We want to treat seizures as they occur, and we want to try to not over sedate. You may have an EEG or continuous EEG. And then also, again, monitor for side effects of our anti-epileptic medications. Okay. I briefly wanted to talk about neurogenic pulmonary edema. This can be seen with ICH and also subarachnoid hemorrhage, which I'll talk about it a little bit later. Affects about 35% of ICH patients. It's thought to be, the etiology is thought to be from medullary injury. Essentially, there's changes with the pulmonary capillary permeability because of inflammatory processes, which increase systemic vasoconstriction and right heart venous return. Early onset, it can be within minutes to hours of the injury, but it can be delayed as well. It's a bit difficult to diagnose because a lot of these patients are very ill. So some of the differential diagnoses would be pneumonia, ARDS, or just pulmonary edema from other purposes or other etiology. So the treatment for this would be obviously treating the underlying problem if we can figure out what that is. Supportive care, mechanical ventilation, dobutamine, inotropes, and then diuresis as tolerated. If we are instituting mechanical ventilation, we want to be careful with PEEP. A lot of times with these patients, we do increase the PEEP, and increasing the PEEP can decrease cerebral venous return, which in turn increases your intracranial pressure. Again, we also want to be careful with our CO2 levels because of subsequent vasodilation and increased intracranial pressure. Okay, moving on to complications of subarachnoid hemorrhage. Again, there are many causes of subarachnoid hemorrhage, but for purposes of this lecture, we're going to be just talking about aneurysmal. Okay. Okay, so a brief overview. I've got a few pictures of different types of aneurysms here. Saccular aneurysms are the most common. And rectal aneurysm into the subarachnoid space and thus into the directly into the CSF, which causes a rapid increase in ICP, which accounts for this worst headache of my life. This is kind of your, you know, if a patient comes in saying, worst headache of my life, it happened very quickly. Sometimes it is precursed by situations that elevate blood pressure, like exercise, stress, things like that, but not always. Our subarachnoid strokes account for about 10%, maybe a little bit less of strokes in total. And like I said, saccular aneurysm is the most common. Along with that worst headache of my life, you may see a brief loss of consciousness. You may see neck pain, neck stiffness, nausea, vomiting, and as it worsens, a depressed level of consciousness. For saccular aneurysms, so there's aneurysms that can be a result of family history and then some that are not. Older age is also a risk factor. Lifestyle choices such as drug use, methamphetamines can increase your risk. Alcohol, smoking, and high blood pressure. So with these patients, our diagnostics initially are CT head, and we're looking for subarachnoid blood. Sometimes if the subarachnoid, if the bleed, if it's been a few days, we may not see that blood. We may be looking at, or we are looking at a CT angio to see if there's any vascular malformations. We also may do a lumbar puncture, and again, these are for patients that maybe have a negative CT head. We're going to look for blood in the lumbar puncture in the CSF, and we also will look for xanthochromia, and xanthochromia is change in the color of the CSF because there has been recent blood. So that could be diagnostic if our CT head is negative. So going back into our nursing school education and talking about CSF development and formation and flow, at any given time, we have about 150 mLs of CSF in our nervous system. This isn't correct. 8 to 15 mLs an hour, excuse my typo here, is produced per hour, about 500 total milliliters per day. Pretty decent amount. So our CSF is formed in the lateral ventricles and the choroid plexus. The CSF flow goes through the third ventricle, the aqueduct sylvius, foramen of Monroe, fourth ventricle, into the subarachnoid space where it is reabsorbed by the arachnoid villi or granulations. So with that, well, actually, let me go into Hunt-Hess really quickly. Hunt-Hess is also prognostication and severity score. This is, again, not something as nursing that you're going to have to be responsible for, but again, I want you to be aware of what it is, so that if you see it in your notes, you can kind of get an idea of the severity of your patient's illness. So you can see a 1 asymptomatic, a mild headache, and all the way to 5, which is comorbid posturing. And most of the time, neurosurgery neurology is going to list their Hunt-Hess score in their note. So backtracking a little bit, hydrocephalus and subarachnoid hemorrhage, this is a common complication. Going back to the CSF production and reabsorption, when blood gets into the subarachnoid space, it can obstruct the blood reabsorption, which can cause subsequent hydrocephalus. It affects about 20 to 30% of subarachnoid cases. More common in posterior circulation aneurysms and intraventricular hemorrhage. So our interventions for hydrocephalus and subarachnoid hemorrhage would be monitoring our patient closely, monitoring for changes in level of consciousness. We're going to do a non-contrast CT head to check the size of the ventricles. If there is indeed hydrocephalus, we are going to consider CSF diversion with extraventricular drainage system, possibly osmotic therapies, possibly diuresis. Occasionally with these patients, we'll see chronic hydrocephalus. With this, we may end up even having to place a VP shunt, which is to offset that CSF production because of changes with the injury from the subarachnoid hemorrhage. Okay. Aneurysm rupture or rebleed. So 14 to 40% of aneurysms rebleed within the first 24 hours. Re-rupture is associated with increased mortality. Not a good thing. Our goal is to secure the aneurysm as soon as possible. Rebleed can occur into the subarachnoid space, the intracranial, intraventricular, or subdural spaces. If there is delayed treatment, aneurysm securement, we may need to reverse the coagulopathies with antifibrinolytic therapy. Some of the predictors of potential rebleed are delayed aneurysm treatment or securement, larger size of aneurysm, elevated blood pressure, and then the presence of blood products in the ventricles, hydrocephalus, and then a higher Hunt-Hess level score, excuse me. You can see a picture of a pretty large aneurysm here. Okay, so what are our interventions here? Blood pressure control is an important one. Cardian drip, labetalol. We want to avoid hypotension to reduce the risk of ischemia. Blood pressure control is going to be based off of whether the aneurysm is secured or unsecured. Unsecured aneurysms, you're going to want the blood pressure lower. You want to avoid rupture. Secured aneurysm, we're going to want more permissive hypertension to avoid vasospasm. So you may see your blood pressures up here in the 180s. If you go too high, higher than 180s, you may want to start keeping a close eye on that and alerting neurosurgery or neuro IR to see how they want to treat that blood pressure. Frequent neuro checks for these patients and stat CT head for any neurologic changes and decreased level of consciousness. Stool softeners to avoid straining. A big one here, seizure prophylaxis, especially in our unsecured aneurysms. These patients are at risk for seizure. And if there is a seizure in the setting of an unsecured aneurysm, that is going to increase your risk of rupture. So you will most likely see seizure prophylaxis for these patients. Oh goodness, okay. Secure the aneurysm. That is our #1 goal here. How are we going to secure the aneurysm? We've got a picture here of a coil, so you can coil the aneurysm. Essentially, this causes a clot to form here so that blood can flow normally back through the blood vessels. Sometimes they also do stent around the area of the coiling. And then also neurosurgically clip, you can clip the aneurysm as well. More so nowadays we do coiling, but this is also a potential intervention. Okay, vasospasm. I have a picture up here of what vasospasm looks like on a diagnostic cerebral angiogram. So you can see that these blood vessels are quite narrowed. Vasospasm typically occurs between 4 and 14 days. It does affect about 1/3 of all subarachnoid patients. The breakdown of blood products causes damage to the blood vessels and subsequent smooth muscle contraction. Unfortunately, a lot of times this has a decreased response to medication. With vasospasm, we risk hypoperfusion and infarction to the brain tissue. Delayed cerebral ischemia is a new focal neurologic deficit that's not attributed to the subarachnoid hemorrhage lasting greater than 1 hour. What are our interventions here? TCDs, transcranial Dopplers, we're looking for vasospasm, and those are usually done daily. We're looking for elevated velocities. Nimitalk, 60 milligrams Q4 times 21 days. Euvolemia, you want to avoid hyper or hypovolemia. There also is the possibility of doing direct intraarterial vasodilator administration. Not done terribly frequently, but can be done. Here we are again with our neurogenic pulmonary edema. In subarachnoid, this increase affects a few more patients, as you can see, as opposed to our ICH. Again, diagnosis may be difficult because these are sick patients. Treat the underlying problems, supportive care, watch your PEEP, watch your CO2 levels. Okay, hyponatremia and subarachnoid hemorrhage. So we're looking at SIADH and cerebral salt wasting because both of these conditions can cause low sodium levels. We're not going to go into terrible detail with this, but the CNS injury causes resultant hyponatremia. In SIADH, I think I put arrows here because I want the take-home points. In SIADH, you're going to see euvolemia or hypervolemia. Okay. Obviously, you're going to see hyponatremia. Urine output in SIADH is going to be normal. So our treatment here is fluid restriction and hypertonic saline 3%. Okay. In cerebral salt wasting, you are going to see hypovolemia and low sodium. Our urine output in this patient is going to be increased. So our treatment here is fluid repletion. We want to replace sodium, but also we want to place volume because this patient's hypovolemic. So you also may start hypertonic saline and then foreign effervescentine to help to replenish that sodium. Seizures, prevalence about 6 to 18%. Irritability in the brain because of the blood. Again, I mentioned risk of aneurysm rupture and unsecured aneurysms. Commonly seen in MCA aneurysm. So I mentioned prophylactic antiepileptics to reduce seizure risk and to prevent rupture of that aneurysm because of a seizure. We're likely going to continue to treat this patient with antiepileptics. A phenytoin in this situation is not recommended. There's worse outcomes. Keppra is the favorable drug. And then EEG or continuous EEG for suspicion of subclinical seizures. All right. So now we're going to talk a little bit about the non-neurologic complications of stroke. So how does this affect other systems in the body? VTE, so DVT and PE because of decreased mobility, because if there's weakness on one extremity, we've got less movement, bed-bound patients. So our interventions here are SCDs, our Lovenox, or heparin. Of course, these are as appropriate based on stroke mechanism. You want to be mindful if it's ICH or subarachnoid. We're going to do SCDs most likely in that situation. Infections and fever. Fever worsens, increased ICP, and has worsened outcomes. So normothermia in all of these patients, that is our goal. Pneumonia and urinary tract infection are the most common types of infection. Pneumonia, obviously, we're worried about aspiration because of dysphagia. Urinary tract infection, there may be post-void residual, incontinence, catheter use. So we want to treat the cause, and we want to institute cooling measures and acetaminophen. Okay. Shivering also can be a result of fever, and obviously shivering is not good for our brain as well. Fever and shivering increase metabolic demand, which worsens cerebral oxygenation. So we do have shivering protocols that we can institute. Some of the cardiovascular complications, kind of the same pathophysiology as the pulmonary. We've got changes with the autonomic nervous system. We can risk myocardial infarction, arrhythmias. Arrhythmias also may be present prior to the stroke and may be the cause of the stroke in an ischemic situation. Neurogenic cardiac injury. You can see left ventricular dysfunction with wall motion abnormalities, which is more common in subarachnoid hemorrhage. Our interventions here are EKG, echo, check troponins, cardiac monitoring, and patient may need a 30-day monitor, depending on if they have arrhythmia. Pneumonia, pulmonary and gastrointestinal complications. So again, we talked about pneumonia, may need mechanical ventilation, neurogenic pulmonary edema, and then also because of brain injury, we may have some abnormal respiratory patterns. So we want to monitor for those. Gastrointestinal risk would be GI bleed. Sometimes this can be comorbidity, stress. It also could potentially be because of pharmacological interventions like antithrombotic therapies. GI prophylaxis and monitoring for GI bleed are your interventions here. And chronic complications of stroke. So once patients leave the hospital, again, like I mentioned earlier, our goal is to prevent these things by early recognition and treatment while they're here in the acute care setting. So some of these chronic complications, we've got, of course, disability, physical dysfunction, hemiplegia, hemiparesis. Post-stroke fatigue is a very common one. We've got your aphasia, speech changes, cognitive changes, trouble with swallowing, maybe some nutritional challenges, Depression, post-stroke depression is a common one, and we like to start looking at that while they're still here in the hospital. Treatment of depression with pharmacological intervention takes some time, 4 to 6 weeks for medications to kick in. We're also worried about secondary infections and injury. Obviously, vision loss. These all preclude challenges to independence. One last thing, I want to talk a little bit about cerebral venous thrombosis. This is also a type of stroke. It affects the venous system versus the arterial system. It affects younger people, women more often. I mean, see this in pregnant women. Thrombosis of cerebral veins or the dural sinus, and that causes obstruction of blood drainage. This can also increase your ICP, blood pressure. So risk factors, hypercoagulable state, oral contraceptives, we see this quite a bit. Like I mentioned, pregnancy, malignancy, infections, trauma. So you're going to detect this on CT or MRI. Your symptoms are potentially a new onset headache or new features of chronic headache. You may also have symptoms of intracranial hypertension. You may see changes with mentation or encephalopathy. You may see seizure, and you may see some focal deficits depending on the location. I mentioned this already. There's also MRV, which is an MR specifically looking at venous flow in the brain. And then our treatments, which I didn't get on this slide, we want to prevent seizures. We want to monitor for bleeding, anticoagulation to prevent clotting of that blood, and potentially surgical intervention depending on the location and severity. Here are some of my references if anybody cares to know. And thank you. I know that was a lot of information in a short amount of time. And I just wanted to open it up to see if anybody has any questions. I will do my best to answer them.
Brian, go ahead.
Good morning.
Good morning.
So I had a patient like a couple of weeks ago that was had to be NPO for like a trach in the morning.
Okay.
Held the Lantus, but then of course like the blood sugar dropped to like the 30s. Had to give like a bunch of D50 jabs. So I think I eventually started D10 after talking to the other NP. But I was wondering if there was like a threshold for like how far completed can a stroke be, and then like D50 or D10 is not like an issue.
So what I generally look at is the blood sugar levels. You know, if the patient's hypoglycemic, obviously that can worsen brain injury. So if you're dealing with NPO, hypoglycemia, I'm a little bit more, I guess, lenient with administration of dextrose containing fluids. Because like I said, obviously you want to avoid hypoglycemia. So a lot of times, I mean, D5NS is more of an isotonic fluid, which would probably be favorable, but if you do need to give dextrose, you know, D10 because of hypoglycemia, I think you just keep a close eye on the blood sugar and make sure that you don't get hyperglycemic, because that would be more of the problem, is the elevated blood sugar. In terms of timing of that, obviously the further out, the better, because you want to avoid those fluid shifts in the early stages. But if it needs to be given, it must be given. I don't know, Angie, if you have any contribution to that.
No, I think our goal is 140 to 180. We don't want it too high. We don't want it too low. And so you just do the best you can to keep it in those parameters. Okay, I'm going to move forward and let Dr. Tadashima take over for us here. Megan, if you'd stop sharing for a minute, please, or stop sharing. we go. Dr. Tadashima is one of our neurointerventional radiologists, and we're very, very lucky to have him here to speak with us today. We're going to let him get started so we don't get interrupted by a code stroke, knock on wood.
Right, yeah, this is really busy stroke center, right?
It is a busy stroke center.
Yep. I think the number one is number one in LA,
We are.
right?
are.
So, can you see my screen?
We can see it just fine.
Okay.
You're great.
Okay, great. Yeah. So, yeah, I've been here more than 10 years, driving a UCLA in Long Beach back and forth and enjoying being here. A great team, the best stroke center, I would say, in LA. And we are committed to do our best, not just, standard of care, more than standard. So I would like to cover endovascular treatment of hemorrhagic strokes, primarily using coils and other devices, and what's the future. So here's my disclosures. I essentially work with every single neurovascular companies developing new devices, and this is a grant support and research support from NIH and some companies. So I have a huge conflict of interest. So everybody knows the brain aneurysms. Usually it happens as a part of an aging process. It's degeneration, slightly promoted degeneration of arteries. That's what happens. We have a brain aneurysm, and roughly 1% of US population, if we look at the just over 40-year-old population, maybe 2%, 3%, it's clearly degeneration, age-related, and more common in female, in adult population. And annual rate of SH is roughly 1 out of 10,000. So 1% population harbors aneurysm, and 10,000 per year, 1 out of 10,000 per year, roughly suffers from a subarachnoid hemorrhage, which means that the rupture rate of an aneurysm is roughly 1%. Some aneurysms, the rupture rate is more than 50%. Some, they don't rupture. So when we see an aneurysm patient before rupture, we have to measure the risk of annual risk of a aneurysm rupture and decide what's the best. Just watching, risk management, risk control, or we treat them. And we have a Miller Children's Hospital here, so we have to think about children. Pediatric aneurysms as well. We looked at the pediatric aneurysms. They're quite different from adult. That may be enough for you to know. At least, it's good to know that they're totally different monsters. It's rare. Some reports says 4.6%. I think that's overestimation. By just working here, you see it, Long Beach and UCLA Children's Hospital as well. Roughly 1% of our aneurysm treatment population is pediatric. And there is no female or male predominance because before puberty there is no hormonal difference, so we don't expect female predominance. High incidence of posterior circulation aneurysms. As you know, adults internal carotid artery distribution aneurysms are very common. The vertebral artery distribution aneurysms are not that common, but in pediatric they're almost like equal incidence wise. And we see more giant fusiform aneurysms. They're always symptomatic, and they have underlying disease because it's not degeneration. There has to be some reason why they develop a brain aneurysm in the pediatric population. We looked at the possible underlying diseases among 35. We identified 7, but essentially, even those rest of the 28 cases, they must have had some underlying undiagnosed vascular fragility. So we have to keep in mind that the pediatric population, they have underlying vascular disease. That's very important because for example, adults, let's say we see a big aneurysm on the right side, the patient has a great collateral. We can sacrifice the internal carotid artery without just treating the aneurysm. If the aneurysm is humongous, we just sacrifice the carotid artery. That's a good option for adults, but the pediatric, it may not be the case because they have a long years to live, and we have to assume that they have an underlying vascular fragility. So if we sacrifice one carotid, they may develop another aneurysm on the other side. So it's very important that we differentiate pediatric aneurysms and adult aneurysms. And speaking about the aneurysm treatment, all started in 1990 at UCLA by Italian neurosurgeon Dr. Guglielmi. Brought his idea to treat brain aneurysms using coils, and Fernando Vinela, he retired. He was here Long Beach as well. They developed this coil called GDC coil. This is the very world first GDC aneurysm treatment case, and everything changed after this. And then very important to remember this study called ISAT, International Subarachnoid Aneurysm Trial, in 2002, using this very primitive, helical coils. We treated aneurysms with clipping and also coiling. And this publication and the study clearly showed that the patient lived longer with a less disability when coiled rather than clipped. But the very important thing to remember is this doesn't mean that all patients should be coiled. In fact, in this study, I think more than 8,000 patients were screened and only 2,000 patients were enrolled because they had to search for an aneurysm that can be coiled or that can be clipped. Okay, so if the aneurysm can be clipped and difficult to be coiled, those aneurysms should be clipped still. ISAT doesn't support that all aneurysms should be coiled. Okay, so here at the Long Beach Stroke Center, many patients are still clipped, although vast majority are just coiled. But again, it's very important to remember we do not push the boundary. If it's unsafe to coil it, we don't coil it. But because of ISAT trial supporting the coiling of the aneurysms, first it was just primitive. But now we have many different type of coils and stents and even liquid embolic materials. We have to choose the best one. So this is some art of coiling or endovascular procedure. That's why we offer 2-year training. But before we choose the best treatment option, even best coils, or whether we should use a stent or not, we have to see whether the parent artery is degenerated, how extensive the injury might be in the parent artery. For example, if there is a tiny degeneration as a result of atherosclerosis or aging, or the bending and blood flow hits the particular point, then we expect a small aneurysm forms with a small neck. But if the aneurysm arterial wall degeneration is a little extensive, then we expect a little wider neck aneurysm forming on the parent artery. So depending on the degree of degeneration, we have to choose the best treatment to the patient. So, the point that I would like to make is aneurysm is just an epiphenomenon. So, just stuffing some coils in the aneurysm sometimes helps, but sometimes it doesn't really help because the real disease lies in the parent artery. So we have to think about the role of the device. Coiling is great. The coil can block the blood flow going into the aneurysm. And if there is some degeneration of the parent artery requiring reinforcement, we use a stent. And also stent helps to retain the coil within the aneurysm without the coils herniating into the parent artery and blocking the blood flow going to the downstream brain tissue. And now we have a device called a web device. It's like a mesh wall device without having to put multiple coils, just to put one device and we can block the aneurysm. It sounds great, but the issue is, unlike coils, we have to look for an aneurysm that fits, that the web device fits. So the coiling, we can just coil anything, but the web device, we have to find the right aneurysm shape. So the web device is not for all aneurysms. But for the right aneurysms, web device is great because just one device and done. If the aneurysm degeneration becomes so extensive and aneurysm becomes very large, then we have to offer radical parent artery reconstruction. That's the flow divergence stenting, this tight mesh stent, and we just lay a stent, and eventually the native tissue covers the stent and the aneurysm disappears. So depending on the degree of the apparent artery degeneration and shape of the aneurysm, we decide what's the best and combine them all together. The issue or the downside of using a stent is we have to put the patient on dual antiplatelet medication. So oftentimes we do not offer stenting in acute subarachnoid hemorrhage case because they're bleeding and they have to have multiple interventions. So dual antiplatelet medication doesn't really help much. So, for the endovascular treatment, we do simple coiling. This is the best case scenario. If it's a wide neck, sometimes use a balloon to retain the coil inside and remove the balloon. If we need a stent, we put the stent. And like I said, if the aneurysm becomes large and the degeneration becomes so extensive, we do a flow divergent stenting. So let's talk about the coiling. Let's say without the stent, if we want to do coiling, what's the phase of the coiling? It's three phases: framing, filling, and finishing. Depending on the phase of the coiling, we choose the best coil. Depending on the aneurysm shape, depending on the patient anatomy, we choose the best one. This is the art part of the procedure. And the framing, we set the diameter of the aneurysm, the diameter of the coil matched to that diameter of the aneurysm. And if the frame works really well, then we can aggressively fill the aneurysm. But the issue is if the aneurysm has a really wide opening and we cannot really do a good framing towards the neck of the aneurysm, oftentimes we end up with leaving a little remnant. So the framing is the key. That's why the framing coils are a little more expensive and a lot of technologies. And some coils, fitting and framing coils, it has a hydrogel. In general, hydrophilic surface promotes tissue heating and also promotes the clotting. So we sometimes use hydro coils for the better heating. Then the finishing means we pack the aneurysm neck. So the finishing coils tends to be very small and very soft. And we put a lot of them because we have to exceed usually 25% of the volume of the aneurysm dome to stabilize the coil mass. So that's our goal. And if you look at this small neck, high aspect ratio aneurysm, it's very easy to treat. We don't need a stent. We put the one framing coil. It doesn't really come out to the parent artery, and the feeding and the finishing, this aneurysm is stable. But an aneurysm like this, basal tip aneurysm, this is a ruptured case. So we didn't want to have to use a stent to avoid dual antiplatelet medications, and quite wide opening. So we had to use a balloon. This is a micro balloon placed across the aneurysm neck, and put the aneurysm coiling microcatheter in it. And just a little technical thing, we have to put the balloon first, always. If we see a fellow before graduation put the microcatheter in the aneurysm and then subsequently put the balloon in the patient, they are not graduating. They have to stay one more year, because if we put the microcatheter in the aneurysm and put a second balloon, they interact. They push the microcatheter placed in the aneurysm, and then the risk of bleeding, risk of rupture is really high. So we have to put the balloon first. And having a balloon placed across the aneurysm neck really helps in case of aneurysm bleeding, even before treatment or during the treatment. It really helps. It's almost like a parachute jumping out of a airplane. It really helps the patient. And you can see that the balloon is not inflating. This is really important because during the coiling, we inflate the balloon, then we deflate the balloon before detaching the coil, make sure that the coil is not really coming out and the coil is staying in the aneurysm. Then we detach it and repeat the process. And this is the final result, although there is some narrowing in this PCA, but the patient actually did really well without having to use a stent. And in a case like this, this is typical, a little extensive degeneration of a parent artery. This is ICA aneurysm, and you can see that the aneurysm is almost like hanging over the artery. It's not really like a small neck. It's not just a wide neck. It's wrapping around the parent artery. So that's the sign that degeneration is extensive. So if you look this aneurysm from a sideways, it looks like a wide neck. But if you see that from the bullseye view, it looks like this. There is no parent artery. So no hope that we can just coil this without the stent. In this case, we have to put the stent that reinforces the apparent artery and also retains the coil in the aneurysm. And this patient actually did really, really well. Here's the packing. This was a coiling almost like more than 10 years ago. When the aneurysm becomes really humongous, then the coiling doesn't really help for many reasons. And also this patient clearly has a 6-nerve palsy. She cannot move her right eye to the ear because of 6-nerve palsy. So let's say, regardless, let's put the coils to prevent from a massive bleeding. Then it may be possible to cure this aneurysm temporarily, but the mass effect remains. Aneurysm. So in a case like this, we do flow divergence stenting. We have to do a radical reconstruction of the apparent artery like this, and we had to put the stent and reconstruct the entire apparent artery, new ICA. And here's the 1-year follow-up angiogram. Aneurysm is gone, and of course, aneurysm is gone. Mass effect is gone, so she regained her eye motion back again. So depending on the shape of the aneurysm, type of aneurysm, clinical presentation, we choose the best treatment option and offer that to the patient. This is another example. This is bilateral giant ophthalmic aneurysms. Patient was almost blind. Can we treat this aneurysm with coils? Yes, of course, but the downside is we leave the mass effect. We leave the big mass in the artery pushing the optic nerve. So in this case, we had to do a flow divergence stenting, and 12 months later, aneurysm is completely gone. Even on MRI, aneurysm is completely gone. Nobody can tell until they see the X-ray, seeing this mesh device. Aneurysm is completely gone, unlike a coiling. Then you may think that why not just do a flow divergence stenting every single case? But there is a downside. This is one of my publication, 2014. We looked at the pressure in the aneurysm. So here's a big aneurysm, partially thrombosed, and we put the pipeline flow divergence stent, and you see that the flow is stagnant and looks like aneurysm is well protected already. But if you do pressure measurement, the pressure remains unchanged. So this is very important to remember. It's almost like it may be counterintuitive, but it's intuitive. If you think about, let's say, you have a port here, a Long Beach port or a Marina del Rey. We don't expect the sea level difference inside and outside the breakwater, right? So if we just separate the aneurysm with a mesh, that slows down the flow, but the actual pressure is the same as the sea level. They remain the same. So it is subsequent thrombosis that treats the aneurysm, that protects the aneurysm, but not the stent. And also we did a simulation as well. This is almost a paper 9 years ago. And based on the angiogram, see, there's a flow stagnation. We are looking at this flow velocity reduction. If we put the stent, flow velocity reduces, and we put the flow divergence stent, the flow velocity goes way down. That really helps to promote subsequent thrombosis. But if you look at the pressure, it doesn't change much. So this is very important to remember that we don't rely on angiogram to determine whether aneurysm is gone or well protected or not. It is subsequent thrombosis. The flow divergence stent induces thrombosis, but they're on dual antiplatelet. So there is a 30–40% chance that after 6 months, aneurysm remains unclotted, remains patent. So that's the downside, because the coiling, once we put the coil, it's protected. Once we put the flow divergence stent nicely, and then 1 year later, aneurysm may disappear, beautiful result. But acute phase, the aneurysm may not be that well protected. So that's the downside. Here's a good example. This is a subarachnoid hemorrhage case from an upper basal dissection. It's a horrible case. How can we fix it open surgically? There's no way, unfortunately. So tried our best to do a flow divergence stenting. We lay a flow divergence stent, although it ruptured the vessel a little bit. But after struggling, we did, I think, a good job. Aneurysm completely disappeared. Aneurysm, the parent artery got reconstructed. The patient was doing well, but a couple days later, it bled. Very unfortunate, right? So angiographic disappearance after flow divergence stenting does not mean that aneurysm is well protected. That's the downside. So please remember. And also, this is a little too technical, but very interesting phenomena. Having a giant aneurysm in the brain is as bad as having a stenosis. It may be a little it's not intuitive maybe, but having an aneurysm, it's a lot of turbulence in it, right? So it's an energy loss. So the heart has to pump a lot of blood into the brain than without the aneurysm because of the energy loss. So after flow divergence stenting, we correct that the blood flow energy loss in the aneurysm immediately. And what happens is we induce hyper perfusion in the downstream territory sometimes. It's obvious on TCD. We started to observe this phenomena, and we are publishing this pretty soon. It's accepted in Frontier in Neurology. That's coming soon, and it doesn't happen all the time, but it happens maybe 20% of a large aneurysm treatment population. The aneurysm was on the right side after flow divergence stenting. You can see that the flow velocity in the MCA got much higher on the right side. This is the same right ICA aneurysm treatment. MCA flow velocity on the right side is significantly faster. So the magnitude of the treatment is humongous. Flow divergence stenting is great. I'm not really denying its role, but because it's so effective, it can induce a lot of good things and a bad thing. So we have to be all aware. That's why post-treatment management is very important, particularly after flow divergence stenting. We pay close attention to the patient's blood pressure. If it goes high, for coiling cases, we accept that, although we don't like it. But flow divergence stenting cases, particularly large or giant aneurysms, we really pay close attention to the blood pressure after treatment. So if we lay the pros and cons, it's very clear that what's the role. So endosaccular treatment, if you put the aneurysm, if you put the coils into the aneurysm, it protects the aneurysm right away, whereas the flow divergence stenting, we may be protecting, relying on the subsequent thrombosis. So the coiling is much better for that, function. But parent artery repair, coiling doesn't do much. Endoluminal flow divergence stenting can fix the parent artery, and it's reliable and dependable. It's durable. Coiling is not that durable compared to endoluminal flow divergence stenting. So, then you may think that why not combining them both together? Yes, we do that as needed. But the important thing is to know the functions, to know the pros and cons of each technology. That's the point. And here's the versatility of coiling. This is anterior choroidal artery aneurysm ruptured case. And you can see that anterior choroidal artery coming off right at the base of the aneurysm. And as you may know, anterior choroidal artery is very eloquent artery. It feeds the lateral geniculate body. So blocking of this artery can cause hemianopsia. And also this anterior choroidal artery feeds the posterior limb of internal capsule. As you may know, that's a motor the fiber from the motor cortex down to the spinal cord. So blocking this tiny artery means hemianopsia and also hemiplegia. It's very eloquent branch. So we had to protect this. And the way how we protect this is it's a technique. If you want to protect something during a coiling, we put microcatheter right next to it. You may think that, okay, here's the artery that we want to protect, so you stay away from it. that's opposite. We put microcatheter right next to it because microcatheter sends the coil away from that structure, right? So by just put the microcatheter right next to the structure that you want to protect, it's very likely that you can send the coil away from it. So we put the a steam shaping and give a certain shape to the microcatheter. That's the art part of our procedure. And this the working angle. My plan was to give a triangular intentional remnant here. And in order to do that, I had to put the microcatheter here. And for that, I gave a steam shaping shape to the microcatheter, and see that the microcatheter is placed right next to the anterior choroidal. Then started coiling and intentionally leaving this triangular remnant. And here is the final result. And you can see that the intentional remnant leaving the anterior choroidal artery. So this is the beauty of coiling. By just combining many coils, we can form any shape, and it can leave even intentionally a remnant to maintain the patency of eloquent branch. And it's almost like it's like a billiard pool game or reading the greens, angulation. If we put the microcatheter, hopefully it goes just a center line, then go downstream, but it doesn't happen. It never goes that way. You hit the wall, hit the wall, hit the wall, hit the wall. This is the behavior of a microcatheter. And then, it's like, and I'm not saying I'm Tiger Woods, I'm not that talented in my domain, but we are doing the same thing, by just seeing this. Let's say there's an aneurysm here, right on the path of a microcatheter. Then it's easy. Microcatheter want to go into the aneurysm, but it doesn't happen all the time. If the aneurysm is located a little more proximal to the microcatheter path, then we have to give a steam shape. Then the microcatheter is stable in the aneurysm. And some other case, oftentimes happens in the ophthalmic aneurysms. If you give a curve to the microcatheter, it doesn't really go into this aneurysm. Because as the microcatheter travels through the outer curvature, it gets twisted, and usually the curved tip points towards the center of the artery. Then we have to give a S shape that makes the catheter hit this inner wall and then going up. So it's a lot of reading, and again, this is the art part. That's why we do offer 2-year training to our fellows, and even the anterior choroidal and artery aneurysm, that's the same. The microcatheter tends to hit the upper wall and wants to dive down. So the aneurysm pointing anterior or inferior, it's very easy for us to treat because microcatheter is inherently stable. But if it's pointing up or posteriorly, then microcatheter doesn't want to go into this small aneurysm. We have to give a special shape to it. That's why we looked at our result of anterior communicating artery aneurysm. The durability of coiling is direction of aneurysm dependent because it's skill dependent. Okay, so, and this is one of the examples of a S-shaped microcatheter, importance of reading the microcatheter course, because microcatheter wants to go along the outer curvature, but this is a very small ruptured A1 aneurysm. And if you just jam the microcatheter into this aneurysm over the wire, microcatheter jumps and we perforate the aneurysm, and it's very unlikely that we can save the patient. Small aneurysm ruptures and the recovery shot is limited, right? So we had to give a shape to the microcatheter that with that microcatheter want to go into the aneurysm, that expand the controllability of the microcatheter. And once we have a nice S-shape, stable microcatheter platform, then put the 3D 2mm by 3 cm coil in it. And again, the treatment of small aneurysm is challenging in terms of microcatheter control. The microcatheter control, degree of microcatheter control is proportional to the size of the aneurysm. It makes sense, right? So the bigger aneurysm, it's more forgiving because the microcatheter jumps by 5 mm, who cares? But here, microcatheter jumps by 5 mm, we are in the subarachnoid space, or maybe in the brain. right? So for small aneurysms, being able to read the microcatheter course is very, very important. Despite all effort, microcatheter, shaping and everything, we cannot treat every single, aneurysm without a stent. This is one of the examples. Very challenging case, ugly looking MCA bifurcation aneurysm. She has a multiple aneurysms other than this. Not a great surgical candidate. Otherwise, this would have been a good clipping case, but we had to offer endovascular option. And one reasonable option is to put 2 stents here, called wide stenting. But the issue of wide stenting is subsequent microcatheter placement is very difficult. Tangle to stent, microcatheter placement, going through the tangled stent struts is not easy. And what's waiting, is a very shallow aneurysm. So if we try to jam a microcatheter going through the stent struts, and if it jumps into the aneurysm in an uncontrollable fashion, then rupturing aneurysm, it's very dangerous. So in this case, low aspect ratio, challenging in microcatheter control, then we had to use a new device called PulseRider. Actually, Long Beach was the PulseRider enrollment site for the US trial. And what's good about this device is it doesn't, it has a really concentrated mesh where needed, not necessarily the entire parent artery. That really helps us to gain access to the aneurysm. And also using this ability of this PulseRider stent, we could put the coil here that's kind of hanging over the posterior surface of the aneurysm. We could put some coils here. And this is a 6 months follow-up angiogram in doing showing a great durable complete occlusion coiling, and she's actually doing great. And we looked at the benefit of using this PulseRider device. This is the first in-man series in Japan. I served as the last senior author of this project, and it was like my case here. It turned out to be really good stent for low aspect ratio aneurysms. It makes sense. And also US trial data. Also, I served as a senior author. 1 year follow-up data got updated and published in AJNR 4 years ago, showing durability of this stenting. It's not as versatile, to be honest. We have to be really picky. We have to have the right bifurcation anatomy shape. But if the patient has a right bifurcation anatomy shape, this device works really, really good. And it's very complicated to choose the best device for a patient, but I think we can do that 90% of the cases, but sometimes it's very challenging. We cannot even predict how a device would behave. And then now we have a better technology. We have a 3D printer. We have we are ordering somebody to print out the device or a 3D model. We have a 3D printer, so we just print them out and do a simulation. There is unfortunate war going on now, but for military mission or like a space mission, they never do without simulation. And medicine should be the same, I think. For a particularly challenging case, we simulate before trying all of them in the patient. So this is one of the examples. We published this 3 years ago. 3-4 case series, and this is this patient. So this is a pretty colossal artery ACA aneurysm, and the issue is this branch. This branch feeds the left side supplementary motor area. Blockage of this branch means that the loss of SMA, supplementary motor area, which is as significant as blockage of anti-MCA. Patient may become mute, left-sided hemiplegia. So this is a very eloquent branch. While blocking this aneurysm, I had to maintain the patency of this branch and did a simulation, intentionally oversizing the stent to let it herniate into the aneurysm. And I choose the best size, the best shape, and the best make and best model. And using that, after multiple try and errors, I chose the best coil size that protects the aneurysm while maintaining the patency of this branch. And this is simulation, and this is actual treatment. When I was in the patient body, I knew that what I want. I knew that which device I had to use, right? So this is tailored treatment, and it's not just in UCLA. As needed, for Long Beach challenging cases, we do exactly the same. We don't differentiate here and there. I'm here. I'm here. So this degree of precision, precise, tailored treatment is something that we offer to the patient here. And another challenging case. This is anterior communicating aneurysm. How we treat it, flow diversion. That's not possible because the parent artery is very tortuous. And coiling, that's maybe possible, but the coil may herniate out in this case because of the super wide neck. Then you may think that, okay, now why don't you put the stent? That's not a bad idea, but this particular case, she doesn't have, this is the right ICA. She doesn't have a left ICA. It was clipped, occluded to treat a bigger aneurysm on the left side. So laying a stent here and inducing possible thromboembolic complication is not, it doesn't help for the patient, not just this particular patient, but the magnitude of the consequence is huge because it's not just a one-sided stroke. She's gonna lose entire left hemisphere because she relies on this anterior communicating artery to feed the left side of the anterior circulation. So in this case, the good thing is microcatheter access was relatively straightforward, and this enabled us to use a web device. Like I said, web device doesn't work all the time, but if the aneurysm shape is such that the web device fits in very nicely like this, it works great. So we didn't have to put the stent. It just stayed within the aneurysm, and after deployment, aneurysm is completely gone like this. This is actually Long Beach case, and the patient is doing great. So, for the right case, it's just one device and done. Works and really helps the patient. And so this is before, and this is after. The aneurysm is well protected. And in a case like this, this is the patient has a history of cocaine abuse, and I can tell that because of the deformation of anterior communicating artery, and this aneurysm is growing, unstable, and on top of that, there is a branch feeding hypothalamus coming off from the aneurysm. So in this case, we expect that the parent artery degeneration is extensive because that's the nature of drug abuse. They promote the aging of the artery, and the patient can form aneurysms in a weird location. So definitely for the long-term well-being, we wanted to use a flow diversion stent. But like I said, flow diversion stent doesn't provide protection right away, and this portion was growing and unstable. So I wanted to coil this, yet I didn't want to coil this takeoff. So we had to do a flow diversion stenting from the left side, from the right side, coiling, and while maintaining the patency of the small hypothalamic artery here. So long flow diversion stenting for long-term durability and parent artery reinforcement, coiling for immediate protection. This is the immediate post. Aneurysm is gone, ACOM is patent, hypothalamic artery, contralateral ACA is all patent, and the patient's doing great. So knowing the functions, the benefits, and the disadvantage of each device, we can, as needed, combine them, offering the best solution to the patient. I don't have, I think, time to go over pros and cons of each technology, but the important thing that I would like to point out here is this chart changes all the time as I have access to a new technology, or let's say flow diversion stenting becomes a little smaller, for example. Then disadvantage may not be a disadvantage anymore, right? So I eliminate a certain factor. So this is very dynamic thing, and as needed, I combine them all together. A very important thing is we do not make a random decision. So based on this chart may be different from the chart of my colleagues, but the important thing is you have your own understanding. I think that's very important. Let's talk about the future a little bit. Like I said, flow divergent stenting, we relying on tissue heating after laying a flow divergent stent. But the issue is thrombosis. Sometimes patient body overreacts to the metal, and excessive clotting means a stroke. So the latest stent has a coating. Now the pipeline stent, Fred stent, the Surpass stent, all US, all devices available in US, they have a coating. And the concept of the coating is it's a biomimetics. One of the stent that we use mimics the cell membrane. So essentially the surface of the stent struts mimics the cell membrane, MPC coating, phosphoryl. So the body doesn't recognize this as a foreign body. So that's a biomimetics. There are so many biomimetics. Best engineering comes usually from the nature, right? Even the latest award, they looks like a bird. So that's what we do. And of course, we are looking at the actual functionality of those latest technology, whether the endothelial cell grows over those biomimetic surface. We are publishing this pretty soon. And also this is one of our, maybe future version idea published, almost like 5 years ago. By just converting a metal surface to superhydrophilic, then we know that we can promote the tissue heating. You can see that the UV specific treatment of metal surface shows more matured endothelial cells and more endothelial coverage, whereas the non-UV treated, not so hydrophilic surface, it's not really friendly for the endothelial cells. So it's not just, we are using devices, but we know the limitation. We are trying to improve what we do to the patient. And this is not, unfortunately, what we have here at Long Beach, but, we are working on the next generation in the future. And in US, this robot is available. So we are using this over the UCLA, and I hope we get that here at Long Beach Memorial pretty soon. When we started this project 4 years ago, this is a press release from Korean robotic company, Aquila Turk, well-known neurointerventionalist, became a chief medical officer to develop a neurovascular robot. I was one of 1, 2, 3, 4, 5, 6, one of 8 members. And it was exciting, and still the Nuvo robotic system is pending approval in US, but in Canada they're already treating a brain aneurysm using a robotic system. We are a little behind. You have to push FDA. Don't do slow processing. But it's not what we can do currently with this robotic system is as long as we can treat aneurysm with a single microcatheter. Guiding catheter placement, microcatheter place, initial portion to be done manually. Then once microcatheter reaches near the aneurysm, then the robotics take over to enhance the precision. That's what they do. And they are doing a great job. But ultimately, here's our recent publication, maybe last year or 2 years ago. Ultimately, we want to, although we are training many physicians, but ultimately, I'm here driving my Tesla. Tesla drove me, to Long Beach, right? So I think treating certain aneurysm or strokes should be done by AI, and that is, I think, doable. So we just discuss about the concept, and also not just a partial robotic treatment or coiling. Theoretically, we can do complete robotic intervention. That's our goal. And this just published 2 weeks ago. Not just a microcatheter. This is a technical guide to use the robot to control large catheter like this. This is my hand. I don't have to scrub in. I'm outside. Or if we can use a remote capability, I can do an angiogram from my house. although it's not approved in US yet, but it's been done in India already 2 years ago, published in Lancet case report. So you can see that from outside, I'm controlling this Siemens 2 Siemens 2 catheter. And once we engage this left common carotid artery, then using a roll map, like we do manually, and advance a wire here, and send up the catheter into the ICA. So it's not scientific fiction. We do this with this robotic system. And also, we just got accepted for Journal of Neurointerventional Surgery. We did 4 complete robotic coiling cases, not in the brain because it's not indicated yet in US. This is one of them. It will be published soon. So if you're interested, please, please read them. Essentially, large catheter controlled by the robot and the micro catheter controlled by the robot as well, as needed touch panel going into this nose. And good, the interesting thing about this patient is that this patient is COVID positive pneumonia, and because of systemic anticoagulation, nosebleed, and the robotic system helped us because I didn't have to go in. It reduces the operator exposure to the COVID. COVID is bad enough, but maybe in the future we may have a worse pandemic, and the robotic really helps. And this is the microcatheter placement. And again, this is the coiling. I'm doing coiling outside of the room. This is the reality. It's not remote future. If anything, it's a near future. And again, this will be published pretty soon. In a couple of weeks, it's going to be on PubMed. So this is the future. It's not the crazy idea. And I believe that what's happening in OR is going to happen in IR. In the OR, robotic system made ordinary surgeons better. It never made extraordinary surgeon even more extraordinary, but the standard surgeon could perform much better job. I think it's going to help because we need more neurointerventionists, and inherently, they're ordinary people and excellent, and we can just make those standard or substandard, submarginal, I have to say, neurointerventionists, better neurointerventionists with an aid from a robotic system. So I think this is my last slide. The conclusion is, neurointervention rocks. This is a great field. Continue to evolve, continue to progress, and I promise that we continue to provide the latest to this Long Beach stroke program. Thank you very much.
Well, thank you, Dr. Tadashima. That was awesome.
That was
And
really
I
good.
agree, neurointervention rocks. That was good. That was so good. Thank you so much.
All right.
Okay, everybody. So Dr. Ramazan's next, but I'm going to call him and he'll be in about 5 minutes. So if you need to get coffee or go to the bathroom or anything, run out. I'm not going to turn anything off. We're just going to take 5 minutes until I get him back on here. But now's a good time to stretch your legs a little bit because I know this is tough to sit for these.
Oh my gosh. That was great.
Fascinating stuff, huh?
Oh, yeah, I like that neurointervention rocks.
Yeah,
I'll be back. I am gonna get some.
you got
caffeine
it.
and Stretch. Oh.
This next one's going to be so good. Yeah, don't go away. Dr. Ramazan's going to do a great presentation here.
So I can just, okay, starting to record. I just want to say that doesn't have as much excitement as his does. So I don't know how robotic, this is just basic bread and butter neurology localization. So it's just basic stuff. Where's the chat box here? Let's see. I'm gonna move it over to the screen here. Chat box. So we can certainly use the chat box, or if anybody wants to speak, they can, but it's open to, I'm gonna ask questions, and sometimes if I don't get anything in the chat box, I'm gonna keep asking it, so. So that'll be the message that somebody answered the question. So again, I think there's different levels of the people's understandings of localization. So this, I'll try to push it more advanced if needed, but we'll just kind of start with the basics and go from there. So let's start with just some basic anatomy here. And this is basically, you know, the structure of the brain. You know, I'm not against the heart, but heart is a muscle with electrical activity. It's got different chambers. The brain is a different structure in that different parts of the brain cause, you know, they do different functions. And that's what's interesting about the brain, that one part is not necessarily, you know, you can't understand one part by just making one algorithm. You just have to understand the anatomy to make it in sense if there's a neurologic process or a neurologic injury that's happening. So that's a very important part of brain function. As you can see, there's the frontal, the parietal, occipital, temporal lobes, and we have the brainstem here, which has the cerebellum, the midbrain, the pons, and the pons and the medulla. So I think the whole structure is that you can certainly have injury in any part of this. And this is a general overall look. You got the frontal lobe, which the posterior frontal lobe is involved in the movement part, the anterior parietal lobes in the sensory part. Some of our speech areas, and most people in the left parietal areas, and the speech areas are expressive speech areas on the left frontal lobe. We got memory in here and the integration with the vision, and hearing is in the temporal lobes. And you got everything basically funneling through the brainstem, through the midbrain, pons, and the medulla to get to the body. So all these have to work in concert, and an injury to any part of this can certainly present with different clinical syndrome. So let's move on to the next slide here. And again, then we have the different function where when you have a lesion to a different part of the brain, you're going to have different loss of function. And the parietal lobe is, for example, you have some of the receptive parietal-temporal area right about here is where you have some of the receptive language function. You have the sensory fibers here. You have the ability to sense the other side, doing mathematics, doing coordinating with the visual cortex is again in the parietal eye. The occipital area is where the vision lands into, and we'll go over that a little bit. We have the cerebellum, which is the balance center, but it also has some work in fine finger motions. We have the frontal lobe, which has a lot of your behavioral components of the brain. So loss of frontal lobe function can not only result in speech problems as well as the movement problems, but it can also affect a personality and thinking. And we got the temporal lobe, which is, again, it coordinates with the other lobes of the brain. Not only is it involved in the speech areas, which is the upper superior temporal lobe, but also in memory, in consolidation of memory, in recognition and other tasks. And then, as I said, the brainstem is involved in kind of that's your highway, that's your freeway to get you from the top to the bottom. But it also plays roles. It involves in the eye movements and your balance and the hearing, not hearing, but your coordination. So that's also an important part. Let's move on to the next here. And when we break down just the motor and the sensory areas of the brain, as you can see here, we have that homunculus. And the interesting thing is, the medial part, Let me go back. The medial part here is where the leg functions are as you move up the body, it also goes further out. And as you can see that certain parts of the body have a bigger representation. For example, our fingers have a bigger representation in the cortex, just because there's you have a lot of function there. So where you have all these fine finger movements and all that we do with our hands. So it has a huge cortical area. Leg doesn't have as much, and same thing with face. So this is kind of representative of how much function this cortical does. And when you're trying to localize it, sometimes you have to think about where the lesion lands. So somebody could come with a hand weakness, and the hand weakness could be from a small lesion to just this area of the cortex. And or you can have a pure leg parasus or plegia, and it could be just a medial frontal or medial parietal lesion right over here where the legs are. Then we can go over some of the arteries of the brain. And again, this is just a representation of how arteries go. This is cut off the vertebral arteries. You got the two vertebrals back here. They form the basilar artery here. The basilar terminate in the posterior cerebral arteries here, and that's the normal circulation. You have the internal carotid arteries that are going out, and they form the anterior cerebral artery, which is this one, and you have the middle cerebral artery here. And when we go back a little bit to this slide, you can see, actually, I have the next slide here. You can see how these arteries are feeding the different parts of the brain, the lobes of the brain. So when we look at the anterior cerebral arteries, so these are the anterior cerebral arteries coming up here, and they're feeding these areas, the medial part of the brain, which when we look at the homunculus, which is feeding the leg, which has the leg function there. And when you go more lateral here, you have the middle cerebral artery, and that's feeding more of the arm and the face areas of the brain. And you have the frontal area here, which is fed by the middle cerebral artery, which is your speech area, and the temporal area, which is also fed by the middle cerebral artery here. As you can see, it's kind of sending all these branches. And when you also look, you have these little tiny branches, and I don't think I can zoom here, but these little branches are perforator arteries. They're coming off the middle cerebral artery. Some of them are also coming off the posterior cerebral artery. And you also have these perforators going into the brainstem. So these also can cause certain clinical syndromes where if you knock one of these out or occlude one of these or have a hemorrhagic lesion near one of these arteries, they can give you a widespread because they're controlling the highways from the cortex all the way down to other parts of the brain. So when that highway is knocked out, a significant portion of a significant deficit can happen. So going based on this anatomy, we go to the NIH stroke scale. And, my role is try to make sense of how this correlates with this. And I hope I can make an argument and get you guys to think about it a little bit of how they work together and what they represent, and how you can, based on a simple examination, which is standardized, you can actually figure out where the problem is. So the NIH stroke scale has about 11 components to it. You got the level of consciousness. You have the questions, which is part of the level of consciousness. You have the gaze. You have the visual pathways. You have the facial movements. You got motor and leg. Looking for ataxia, sensory deficit, language function, language. Structure, which is not necessarily not language structure, language tone, which is the dysarthria, and then looking at it, which used to be called neglect, extinction, and attention. So when we look at this, you can kind of say, well, where does level of consciousness fall in the NIH stroke scale, and where's the gaze fall, and where's the visual pathways fall, and the facial palsy comes, and motor and leg. So these are not necessarily straightforward. You can say, oh, motor and leg are exactly this part of the brain. So you have to kind of fit it together. Limb ataxia, where is that from? Is that from a cerebellum, or somewhere else? So what about sensory? Where is that from? Language function, is that one area? What type of language function it is? And the dysarthria, where that comes from. So I'll try to kind of point this out while we go through this here. Let's go to the next one. So in the NIH stroke scale, you have the level of consciousness, you have the awake patient, you have minorly, not alert but easily arousable, you have repeated stimulation to get that, and then obviously you have no responses or reflex responses, which is the worst response. And once you hit these lower numbers, the higher numbers or 3, you're going to end up, having significant deficit, because once your response is low, then most of your other parts of your NIH stroke scale is going to be affected as well. So that's the first part of the NIH stroke scale. The second part of the initial part of the NIH stroke scale is the wakefulness, which is a couple of questions, a couple of commands to follow, and a couple of questions. And that kind of, in essence, is not only the level of arousal, but also affects language function. And what they say is the problem with one of the problems with the NIH stroke scale is that it's heavily left hemispheric weighted, right? Because if you can't answer 2 questions, and if you can't answer commands because of a language deficit, but you're still pretty awake with a 0 here, with somebody who has some level of aphasia, you're going to automatically get 4 points here. So somebody who has an aphasia, so a left hemisphere syndrome, could automatically get 4 points plus everything else that's gone, versus the right hemispheric syndrome is not going to have those 4 points. They're able to, their language functions intact, so they can answer all these questions. So that kind of is a bias of the NIH stroke scale with what we deal with. So NIH of 17 could be in the left hemisphere could be equivalent to a 10 or 11 in the right hemispheric lesion. So that's truly remarkable, because that may change how you think about a patient. So if a patient has an NIH of 7 with a occluded artery, you may say, I'm going to treat it, versus if the NIH is 1, you say, well, it's a 1 or 2. I'm not going to treat that blocked artery because it's a low score. So that truly may affect your decision making and treatment. So just be aware that this may feel, while it's orientation, but it also has language function in baseline. Next, we have the gaze preference, and I think I put this, and Angie knows that these are slightly different in her slides. I've made some modifications to them. So I'm just going to quickly go over the visual pathway here, just to kind of have a basic understanding of it. So what happens is these signals are coming from the frontal lobe. That's where the visual pathways are. They come in, they go across, and what they do, they go into the brainstem. And what they're doing is they are sending signals to both muscles. So what this left frontal lobe is telling your eyes to look to the left. And they go into the brainstem and they affect the different nuclei, of the 3rd and the 6th nerve. And in that scenario, they tell the muscles of the different nuclei to move in one direction. And that's what it's doing. So when you knock out one of the frontal lobes, it's actually the gaze that's being affected. The one side muscle, that these fibers are going to one side, 2 muscles that are moving the eye to one side. And that's what's really affecting it. And that's what the gaze deviation is. So this would be a conjugate gaze deviation. So this conjugate gaze deviation, where one eye, like this one, number 3, this is more of a disconjugate. One eye is straight, the other one is not, versus this is a conjugate deviation, where both eyes are the same. So, and that certainly is going to make a difference. These conjugate gaze deviation, where both eyes are in the same direction, are probably from a cortical lesion. Sometimes it can be from brainstem lesion, versus this conjugate one is probably not from a cortical lesion. There's no way you can cause a cortical lesion to cause something like that. So that's just something to be aware of, that when you're looking at eye movements and when you look at gaze deviation, be aware. And again, in the NIH stroke scale, you have palsy in one or both eyes, and then you have the forced gaze deviation. So forced gaze is basically you try to move the eye, move the head in the opposite direction, and see if the eyes move in the opposite direction of the head movements. And if you don't do it, you give that force. And that comes with a severe or significant lesion in the frontal lobe. Next. The next part, and this is completely separate, is the visual field pathways. The visual field pathways are different. The visual fields are not the same as as your gaze deviation. This is your vision. This is what you see. So the last part was the eye movements. This is actually vision. This is what you see. And the visual pathway, the way it does it, it takes the same side of the vision. So this part, the orange part goes to the same part of the retina in both eyes, and they go in and conjugate through one pathway after the optic chiasm into the optic radiation, into the thalamus, and into the occipital cortex. So it's the one side of vision that corresponds to one hemisphere. And on the opposite side, same thing. It's the one side of the vision. The blue pathways are looking on the retina, are looking at the right side of this visual cortex, and they're going all the way to the left occipital lobe. So in this scenario, what you see is you see that now. If you say have a gigantic bleed from a pituitary mass that knocks out both pathways in the optic chiasm, that certainly could knock out the whole pathways and cause that. So just be aware that this is not the same as the eye movements pathway. Any questions so far? Am I still on? Hello?
Yes, you're good.
Okay, thank you. Okay, so let's get some answers here. I've got some letters here for you. So go ahead and put in the chat. I need to see at least 3 or no 5 before I move on. So I'll stay silent. So for this first type, where's the lesion? You got the different letters. And this is the right eye, this is the left eye, just in case. I'm talking about this one here. So which letter would correspond to a lesion that would cause this type, where the right eye can't see and the left eye is fine? You can speak too. I'm going to go with Melissa if nobody answers. Hello.
Hi, Dr. Ramadan, looking for a package.
I didn't sign anything though. Okay, so let's go. So what is that? So the whole right eye is not seeing that. Okay, so when we look at these this pathway, let's take a look at it again. Where could a lesion completely cut off the vision to the right eye? So is it going to be cortical or is it going to be somewhere else in the visual tract? So remember, this eye, both the medial and the lateral side, or the temporal and the nasal part of it, are going through one optic nerve. And that optic nerve at the optic chiasm then separates, where the temporal part and the nasal. Sorry, I'm going to pause and I'll wait for some more answers.
Hi, everyone. This is Megan stepping in for Angie momentarily. We'll just give Dr. Ramazan a moment. He is on code stroke right now, so I'm assuming he's getting a code stroke call. Thank you for your patience.
Okay, sorry, I'm back. So when we look at this, so the lesion, the only way you can get a brain, if you knock out this, or you not, if you have a B or F lesion, when we look at it, you're gonna affect all the blue fibers. So the blue fibers are coming from part of this eye, the right eye, and part from the left eye. So in this scenario, the only way you're going to knock out the vision in one eye is either lose that vision, that globe, for example, get something punctured to it, or some trauma, or you actually get lesion to the optic nerve. So, and this is a classic stroke syndrome type of a thing. Would be for example, a optic ischemic neuropathy, where the nerve where the artery to the eye actually gets infarcted. So in this case, the first lesion would represent E. So the E would be what gives you this part where the right eye is blind and the left eye is perfectly fine. So let's go to the second one here. And here we have the left side of the vision in both eyes is now working in the right side. So which one was that correspond to? Okay, so I hear I see G's, and anybody else? So I think the way we would look at this is your visual field. This is the left side of visual field. This is the right side of visual field. And the left side of visual field is dark. So if you knock this out, it's going to be the orange one. So what letters correspond to the orange one? And there's two letters that correspond to the orange one, the G and the C. So in this scenario, if you knock out the optic radiations or the optic tract, not the optic nerve. The optic nerve was the E. In both of these scenarios, you damage the occipital cortex. That gives you the same thing as the pathways to the occipital cortex. So in this scenario, it's actually both of these that can give you a part of that. And that corresponds to an NIH score scale of 2, which is a complete hemianopsia. If there was a quarter of the visual field that was affected, would be partial hemianopsia. And if it's a half, and if it's bilateral hemianopsia, which is basically somebody being blind, that's a score of 3. And cortical blindness is a very uncommon syndrome from a stroke, but it can happen. This usually happens in a patient who's already had a visual field deficit. For example, somebody who's had a lesion on level B, and then the new stroke comes in and affects a lesion level C. So this would be bioccipital strokes, and that results in a cortical blindness. And I've had several patients have that where, they come in, they say, oh, I've had a stroke in it before, which affected my vision, and now I'm blind. And then you do a CT perfusion and you do a CT, which is negative, but then CT perfusion shows, oh, there's a old stroke in the right occipital lobe, and now you have a new stroke in the left occipital lobe, or that you don't see it on CT. So those potentially could be get treatment, at least medically for that. So that's a clinical syndrome to deal with. Okay, next. This is the easiest one, I think, to see. If you have a minor facial paralysis, there's a 0 here too. If there's no face is symmetric, if it's a subtle change, it's like this person, I think, is at least a 2. It's a partial paralysis. If it's completely paralyzed where there's no movement, it's going to be full. Just be aware that if the eye is involved, if the forehead is involved, and then that's a central lesion, that is not, that's a peripheral lesion. That's from the nerve itself and not from the brain. So usually when you knock the nerve out, the whole half the face gets involved, versus when the nerve, the brain is involved, it's the lower part of the face, and it spares the eye and the forehead. And we have different categories for the motor examination. We have mild drift, doesn't hit the arm with 10 seconds. Then it falls down to the bed. You got no effort against gravity, again, no movement, and you've got the 0 to 4 score for that. And you've got the leg being the same thing, but it's only 5 seconds. So the leg, you have to, if you can hold it for 5 seconds, that's a no score. If it drifts slightly, is a 1 point. If it falls against gravity before hits the ground by 5 seconds, it's a 2. If you have a little bit of it movement, but the no effort against gravity, that's a 3, and then no movement's a 4. This is very similar to the motor grade that we use in the neurologic examination, slightly off of that one. And then we have finger to nose, which is limb ataxia, and heel to shin. Basically, the patient has their finger, they go from the nose and all the way to the finger. I usually and I was taught that you want to have the patient stretch their hands all the way out instead of just doing it like this, because then you're not really getting the whole gist of the picture. So you want to do a finger to nose where you stretch that hand all the way out to get a good finger to nose. And the heel to shin, same thing. You have the right foot go from the knee all the way to the foot and go up and down, and you see if the foot is wavering. And so if you get limb ataxia in one limb, it's 1 point, and limb ataxia in two limbs, it's 2 points. Sensory examination, you have no loss, a little bit of sensory loss, and obviously severe sensory loss is 2 points. So that gets you that. Usually you like to use something that's a little sharp to be able to attest to that. Just be aware sometimes where you have neglect, there may be neglect and not sensory. So you have to be aware of that, and we'll go over that in a shortly. Then we got aphasia, and aphasia has certain tests, and then a stroke scale, you have this picture that the patient has to describe, or they have to name these objects. And when we look at these, if it's a mild to moderate aphasia, it's 1 point. Remember, you also get extra points in aphasia when you don't answer the orientation questions at the beginning. So you technically can actually have a higher score for a left hemisphere region. And you can have a severe aphasia where it's really hard for the patient to speak. And if they can't speak at all, that's a mute that gets a score of 3. And when we look at localization of it, again, this doesn't separate it out. This doesn't tell you where the lesion is, but you can guess where the lesion is. This is built for a large stroke, but for a smaller stroke, you can have just an expressive aphasia or a receptive aphasia. Receptive aphasia is one of the hardest ones to pick out. Even experienced physicians are having a hard time, especially in the emergency department or other places, where the patient is speaking to you very fluently, but cannot understand you. And that's a very key determination of a receptive aphasia. So you can ask him a simple command, don't show the patient, let's say, don't say, show me 2 fingers, say, show me 2 fingers, and they just don't do it. And they're talking like, yeah, I'm fine, I'm doing okay, I came from home, there's no problems with me, my name is X. So they're talking very fluently, but they just really can't understand what you tell them. And that's a marker of a receptive aphasia. And usually this number 11 will correspond to it there. And then we got the neglect part of the examination. What happened to the dysarthria? Sorry, I lost the dysarthria. So dysarthria is, I think I deleted by mistake. And you got the mild and moderate dysarthria and no dysarthria. Those are the three levels of scoring there. And then remember, dysarthria is the how the words are enunciated. So then the aphasia is how the words are spoken, the sentence structure, versus dysarthria is the enunciation of the words. So somebody, if you stick a bunch of candy in your mouth and trying to talk, that slurs your words, and that's more of a dysarthria. Versus an aphasia, the words can't come out. So, so there's a difference between the two, and you have to separate those out because they truly and this is a cortical syndrome. Aphasia is the cortical syndrome versus the dysarthria can be a cortical or subcortical lesion. So if somebody is dysarthric, they could have a lesion here in the motor cortex, but they could also have a lesion anywhere down that motor pathway, going from the subcortical tissue all the way into the brainstem, all the way down into your mouth muscles of your mouth. So any lesion can cause dysarthria versus an aphasia would be generally a cortical syndrome coming either from a frontal lobe lesion or a parietal temporal lobe lesion. And then we have neglect and or extinction, basically. And this is usually checked by visual field testing and double simultaneous stimulation, where you touch both arms, and I generally do that, and you do that for every patient, every time you do it, and it's very quick. You ask the patient, which arm am I touching? You touch the left, you touch the right, or you touch both of them, and you ask them which side am I touching? And that's a very quick assessment of it, and usually the neglected patient is not really realizing the side that when you stimulate both sides, they only realize the side that's working and they ignore the other side, and that goes with that. Even if when it's even more pronounced, you can put that arm in front of the patient's eyes and say, "What is this?" And they don't even recognize their left hand, and that's a more severe and profound attention. So just be aware that that's part of what the extinction examination is. And again, I'll always do that double simultaneous stimulation when you're assessing a patient, because that's a mark of neglect. But be aware that if somebody has a severe sensory loss, so if they can't feel that side, guess what? They're not going to be able to sort out neglect from or extinction from a sensory loss. So you have to actually ask the right questions. Does these feel the same? And the patient says, "Oh no, I feel less on the left side." Do you feel anything on the left side? And you ask them, "Oh, I don't feel anything on the left side." So, but if they say, "Oh, I feel that," and then you do the double simultaneous stimulation where the mildly decreased sensation, and you do that, and you find, "Oh, okay, yeah, there's some neglect as well." And again, neglect is a cortical syndrome. Extinction is a cortical syndrome. It's fitting into the parietal areas of the brain. So versus a sensory loss, pure sensory loss can be either cortical lesion or subcortical lesion. So on its own, when you have extension, when you have aphasia, when you have gaze deviation, those are cortical strokes. Those are potentially where the large arteries are involved. Versus if you just have one of the sensory loss or just pure motor examination with nothing else, they're going to be a subcortical lesion and not necessarily a cortical lesion. Any questions? No? Okay, nobody's asking questions. Let's move to the next, just a couple of cases here. We have another 15 minutes or so. So we have this 52-year-old gentleman. He's got diabetes, hypertension, atrial fibrillation, a smoker. He comes in with speech problem, right side weakness. I'm going to call him in a second after that. Oh, so let's go back to this picture. What happened to my slide? Okay. It was with caregiver. It was not trying to eat his food. 10 to 30, he had speech problem. Paramedics were called and patient taken to the hospital. He's awake. He answers simple questions intermittently, but has limited comprehension. His pupils are reactive. Extra arm movements are intact. Left gaze deviation is noted. So we got some comprehension problem. We have a left gaze deviation. He has a large bill, so facial droop is difficult to assess. He has neglect on the right, and right upper extremity is plegic, right occasionally has occasional movements. Left side is good, and then has sensory loss. So let's go back to our, I don't know if you guys have a cheat sheet. What we would score this patient is the level of consciousness 0, 1. What's his level of consciousness?
This is where you're all supposed to play along. Okay, I get a 0 I got some zeros in the chat, Dr. Ramazan.
Okay, we got some zeros. How about this answer simple questions intermittently? Okay, so exam is not is direct, but potentially it could be that. Okay, let's go to the that's the level of consciousness. Level of questions and commands. Anybody have anything you're going to put? What number would you give 1A, 1B, and 1C? The total number of points for those. Would you give them a point? And you can say you didn't give me enough information, so that's an option. Okay, I'll take that.
I got a 1 question mark.
Okay, gaze deviation.
There you
What's
go.
the best gaze?
He was looking towards the stroke.
We're getting ahead of ourselves, Angie.
I'll be quiet.
What would you give the gaze? If nobody answers, I'm going to say it's a 0. Okay, we got a 2. We got 2 2s. Okay, good. At least a 2, at least a 1, but most likely a 2. Okay. Let's go back to the case here. So there's no visual field information here, so I'll pass that. Facial palsy, can we assess that? How many people would say, okay, I put a big beard in there for a reason because it was hard, but how many would you guys say it's not a 0? Would somebody say it's not a 0? Knowing the rest of his examination. No one answers means, okay, good. I got at least one person saying it's not a 0. Yeah, that's correct, because what do you expect? Look at the rest of his examination, and what you understand from it is he has a lot, but he has a severe plegia in the right upper extremity and right lower extremities involved. So those are also are pretty relevant stuff. So, you know, the odds of you just knocking out just your leg and the arm and then you got neglected and all that is low. So it's probably not a 0, just his beard doesn't let us see it. How about the motor in the arm? What number would you give that? Anybody else? We got a 3. Well, just focus on the right upper extremity. And then we'll go with the right leg. So let's do the right arm. So I've got a 4 and a 0 for the uppers. But I think the 4 is correct. He has no movement in his right upper extremity. He's plegic. There's no movement. And the right lower extremity has occasional movement. So what would we say with the right lower extremity? And again, this is kind of the mental exercise of saying, how am I going to convert an exam, a neurologic exam, to an NIH stroke scale? And that's kind of where this is this exercise where everything's not straightforward and clean cut. You're just trying to kind of assess and give it a number. Right, there's some movement there, but it sounds like it's not really able to lift it up. So I would say probably a 3 is a very good, reasonable number here. But again, based on what I can say from this. But again, this is a patient. And then how about the language? What would you call that? What would you give him for his language function? Is it going to be a no aphasia, mild to moderate aphasia, severe aphasia, or mute? So we got a couple of ones here. Mild to moderate, okay. And that's probably a reasonable answer. Look, he's following some commands. He has some limited comprehension. So he's probably going to be answering simple questions. So it doesn't look like he's severely aphasic. He's answering a few questions. He's having some comprehension. So it's probably at least a moderate aphasia, but not getting to expressive one where you can't understand anything. Okay. And did I mention neglect here? Sensory examined right lower extremity occasional. He does have neglect on the right. And then this could be either 1 or 2. Again, this is not, you need a little more detail, but at least the 1 for this point. So you're looking at this patient, maybe we got a 1 point here, that's a 1. Gaze deviation was a 3. Visual fields where we're not assessed. We have a 4 here, 4 and 4, 8, 8 and 3, 11. Limb ataxia in this case would be 0 because those are the plegic size. Sensory, probably a 2. We got 13 there. Language is a 2, 15 there. He's probably mildly dysarticulated. That's a 16 and 17. So this would be an NIH stroke of 17. And I'm translating a clinical scenario with this much information into a score here. Now, am I going to be off? Am I going to have an error in this? Yes, I probably will, because I'm reading a topic, but I came up with a number here. And that's kind of the whole point of trying to think it out and say, okay, yes, I don't have it exactly, but this is what it looks like, and I've done this in practice, and that this is most likely what it is. And looking at this, so I just like people to say what colors of this cortex based on your examination involved. So we know this is a right-sided right body deficit. So which colors in this brain are actually involved? I'm going to call this light purple, red, green, dark purple. I guess this is orange, yellow, and green. So all the colors you guys think, just put them in the chat. Which colors do you think are involved in this lesion? I need at least 1 response. So I've got a red and a green. We've got orange involved. We've got light purple and green. Orange, red, green, red, orange, red, red, and green. How about yellow? Anybody for yellow? What does yellow represent? What does yellow do? Any thoughts? What does yellow do? Yellow part of the brain? What part of the speech? Speaking or understanding? Okay, great. Angie, you're cheating. You're not supposed to say. Okay, yeah, Angie answered it. So this is a receptor aphasia. So no Googling. That defies that. So we got a gaze deviation. What part of the brain does gaze deviation? Light purple or dark purple or red? What is going to do the gaze deviation that we noticed? Great, light purple is correct. So we got light purple involvement. Do we have red involvement? People had said red, so we got red involvement. We have green involvement. How about we already said we have some yellow involvement. So far we've got this part, this part, this part, and this part of this whole brain involved. And that's kind of coming around from our NIH score scale, which we basically called it with a 17 plus or minus 3, based on what we could do from a written description. We called that we have a frontal, parietal, and superior temporal lesion. And which artery does that fall into? I don't know, you guys, I can go back to the arteries, but which artery does it fall into? Okay. Okay, good. So it's going to be a middle cerebral artery. When we go to our perfusion scanning, which is the one that tells us cortical deficits here, we see that, you know, this is probably slightly off for this patient because we thought there was some receptor aphasia, so it's probably somebody else's scan, but we do see the delay in this part of the brain, which is what this shows. This is the delay. This is the part that's ischemic, and then we have the dark brain here, which is the dead brain, and this looks like it's potentially a matched brain deficit. So the bright one with the dark match, so it looks like that. And then when you look at the artery, we look at here, the left middle cerebral artery is blocked. So that corresponds with this left middle cerebral artery blockage with tissue that's probably not that's salvageable on him. Although it sounds like he came on time, maybe his history was not correct. Okay, any question about that case? We'll do one more, I think, with time, so. Okay, we'll go to the next one. Nobody asked any questions. 66-year-old, history of COPD, CAD, MI, diabetes, presenting with several hours of double vision. He had a headache about a week. He was in the ER where he had a CT of the head. He reports coming prior to the emergency department. He noticed that cars were coming and was seeing 2 cars coming. At that point, he decided to come to the hospital. He has no dizziness. Okay, he's awake, alert, fluent, good comprehension, no dysarthria is appreciated. Visual fields intact. Extraocular movements that show that the left gaze, there's a slight delay in the left lateral rectus muscle. He does have nystagmus, horizontal nystagmus, left greater than right, eye movements. There's a right nasal labial fold decrease, facial sensation symmetric. Strength is 5 out of 5 bilaterally. Pinprick light touch equal. Trace right arm ataxia noted. Okay, let's go to our level of consciousness, A, B, and C. What number would you guys give it? Okay, great. We got a bunch of zeros. Gaze, DV, gaze. What would you say? Does the nystagmus give you any points? So we got some ones here. Okay, so we could be calling this a partial visual, partial eye movement problem, okay? Visual fields. What number would we give visual fields? 0, 1, or 2? I have no answer so far. Yeah, I'll go back. All right. 0, 1, or 2. We got a couple of zeros there. Thank you. Got 3 zeros. Okay, that's correct. This visual field pathway is not involved in any way here. This is the eye movement problem. Okay. Facial palsy. Okay, we got a ones out, lots of ones there. Okay. And motor arm and leg. Okay, we got zeros there. Limb ataxia. Oh, let's go back 1 second. We're not going to limb ataxia yet. We're still doing motor. We got a one person saying 1. So again, you have some knee pain there, whether you count it as this becomes a greater type of a thing. If you say, well, there's knee pain's limiting his movement, so should I even give him a point? And that becomes a judgment. I think sometimes it's hard. Sometimes if you want to be a purist, you're going to say, yeah, it's a 1. But if you feel it's, there's no weakness there and that he's able to hold it adequately and the pain is, he's ever able to overcome the pain, you can give him a 0. Okay, so we'll go with that. Let's go with 0 or 1. Limb ataxia. We got a 1 there, okay. Sensory. Yes, that one was sorry, ataxia. Sensory is the next one. Okay, we got zeros. We have a pinprick and light touch are equal there. Great. And language. Language is 0. He's alert, awake, fluent, good comprehension. That tells you. And then dysarthria. Again, no dysarthria is appreciated. That's another one. Okay. And neglect. Right. It sounds like based on this verbal description, there was no neglect there. Okay. Okay. So we have an NIH of 1, 2, 3. Maybe a 4 for that leg that had knee pain, but at least a 3. And in this scenario, this was an MRI that was done. And when we actually look at the T1, which is similar to CT, but has different coordination, really no hemorrhage there. Nothing acute, but when you look at the DWI, there's a small cerebellar, and looks like the cerebellar tracts are involved. Probably just close enough to maybe this one to some of the descending pathways to cause that double vision there, where it would be from this one versus the ataxia, maybe from this lesion more posterior. Let's see what else we have. And in this scenario, it looks like the right vertebral artery has got a problem here. As you can see here, it's kind of tapered down. So So fortunately, with this vertebra already having this potential disease here, patient did not have a major stroke, and this is not a big stroke. So patient probably is going to do well with this. Okay. I think my time is up. Angie, is that correct?
Actually, you're supposed to go to 3:15, so you are 11:15, so you
Oh,
had,
we're into-
if
we're
you
into-
can, go ahead and do the last one,
Okay.
it'd be great.
Okay, let's go to the case 3. Patient is a 46-year-old. No past medical history, was on the golf course eating lunch. And his face felt a little off. Checking the mirror, noticed that he had a facial droop. He called the paramedics, came to the hospital. He had some left-sided symptoms as well. Okay, he's awake and alert. His speech is dysarthric. His pupils are reactive. Extraocular movements are intact. Visual fields are intact. Left facial droop is noted. Facial sensation is symmetric. Left arm has trace ataxia, minimal weakness. Left upper extremity and lower extremity. Right side 5 of 5 cerebellum, slightly decreased. Rapid eye movements on the left hand and intact finger to nose bilaterally. Okay, let's go back to the NIH stroke scale. 1A, B, and C. Okay, we got a bunch of zeros there. Sounds good. Gaze. Okay, we got zeros for the gaze. Let's go to. I forgot my next one. Oh yeah, visual fields. Okay, we got visual fields being a 0. Facial palsy. We got 1s and 2s, so I put in here speech is dysarthric. I didn't quantify it, so 1 or 2 is an acceptable number here. More likely, it's probably 1 just because it sounds like this is a milder syndrome, but again, just looking at it, okay. Motor arm and leg. Let's just do the right side. I'm sorry, left side. Let's do 1 for the arm, 1 for the, 1 score for the arm, 1 score for the leg. Okay, so we have 2 1s for that one. Limb ataxia. Why is it a 1? Because it says finger to nose is intact in the last sentence. Would you say it's a 0 or 1? Okay, we'll go with a 0 on that one. Sensory. Facial sensation symmetric. So we have the left arm ataxia, but we also have the cerebellum, but the finger toes are intact. That's why the last question, the ataxia is probably from the weakness, like Megan said. Sensory, let's see, facial sensation symmetric. And I think that's all you got here because I didn't write the rest of them here. We can go with a 0 there. That's all we have. Language. Aphasia, no aphasia? Okay, great. Dysarthria, mild to moderate, severe. Okay. Let's go back to extension, any neglect? Okay, very good. Okay, so we've got, let's go back to this. We got no gaze, we got no gaze, no visual, we got a facial of 1, 1, 1. That's 3. Potentially 1 here, but that could be 0 because his finger nose went back. So that's a 3, 1 for 4. So that sounds like an NIH of 4. So the next question is, any cortical signs? The answer to that is a yes or a no. Cortical signs. No answers yet. I've got 1 yes so far. Any more? We got 2 so far. Okay, what were we looking for cortical signs? Which are the ones? Language, neglect, maybe some level of orientation, gaze palsy. So any of those have any scores? So right, so this is probably not a cortical event or cortical lesion. Just because we got on our NIH Stroh scale, we got no gaze, we've got no language no language function. There was dysarthria, which again, as I mentioned, dysarthria can be at any level of function. So that could be a cortical or subcortical lesion, and we have no neglect. So based on that examination, more likely you're not dealing with a cortical lesion, we're dealing with a subcortical lesion. And subcortical can be at any level. Okay. And then we go on to the CT. And this was his lesion. He had a small little hemorrhage on the right basal ganglia. And that's a typical subcortical lesion. It's not too big, but it affects all those pathways that are going from your sensory, from your motor, which includes your ability to enunciate in there. And that's where this lesion is. So this lesion is in the basal ganglia causing this deficit. I have a picture here. Okay, let's quickly go over the last case here. Any questions with that one? About cortical and subcortical? I'm only asking questions. Okay, I'm moving on. 78-year-old with mild dimension hypertension at home eating dinner. As soon as he completed her meal, she states that she lost vision in her left eye and not the right. She also states she had a mild headache, went to bed, family woke up after an hour, noticed she was confused and not her usual self, brought her to the hospital. On exam, she was awake and alert, normal speech, comprehension with mild forgetfulness. EOI, extraocular movements are intact, symmetric facial movements and sensation, visual acuity was normal, but she had loss of vision and left visual field. Her exam is normal, sensor is normal, there was no mild neglect on the left. Okay, let's go back to our NIH Stroh set. Level of consciousness, 1A, B, and C. Okay, great. Gaze. I'm going to put it in so we can separate gaze. Gaze. So I'll move back here. Okay, next is Visual fields. Visual fields, score. Okay, let's go back to our visual field exam. Which one? 0, no visual loss, partial hemianopsia or complete hemianopsia or bilateral hemianopsia. Is the patient blind? No. Is it loss of a visual field? Okay, we got one answer. Yeah, so she actually has a visual loss in the left visual field. That's a complete field. So that 2 is actually correct. So if you have it as a quadrant, that would be a 1, but if it's a half vision, it's a 2. Okay. Motor arm and leg. Sensory. Language. Dysarthria. Okay, and then last part is extinction. So what's our total NIH stroke scale for this patient? Okay, great. Next question is cortical or subcortical? And we go to our brain over here. Where's my brain here? What color is affected? This one is light green and this is green. So just to separate the two, light green or green. This is purple, light purple. Okay, this is light purple, light green, purple, green. Okay, so if you want to use these, you can go with light colors and these ones, and then go with regular. Any other colors involved? You gave the patient an NIH stroke scale of 3. Or let me put it another way, any other potential areas involved? So we just have green, right? That's it? Okay, let's go look at the lesion, see how many people are right. We got a few purples in there as well. There's your lesion there. It actually involves the occipital as well as including into the parietal lobe. And when we look at the visual field, again, that was in the right, so it's over here. And that corresponds to the vision on the left side here, right? And that's, remember, these go across. I just think about the crossover. The left side of the vision goes to your right occipital lobe. The left side of the visual area goes to the left occipital lobe. So they just kind of cross. Okay, so, and I think that's our lesion. This is another same thing. We got the same picture, just slightly different here, where you actually have a lesion here in the right occipital lobe corresponding to the left visual field. And that was my last slide. Any questions for me?
We have a, that was fun. I think it was great. Thank you. No questions for Dr. Ramazan? All right. Well, thank you very much, Dr. Ramazan, and we made it through with no code strokes, I think. So,
Okay, thank you. Bye-bye.
yay. Thank you too. All right, next we have Rebecca. And Rebecca's gonna do some stroke documentation, but she makes it pretty darn fun. Okay, there we go. Here she comes.
It's not really fun.
It is fun. Don't tell them that. At the end of this, when she's done, I will repost the evaluations. So you guys can go in and do them. I'll also send them out on email just in case you miss them. But Rebecca is the stroke coordinator here at Long Beach Memorial, and she's exceptional, and I'm looking forward to her presentation. You go, girl.
Well, thank you for saying all that.
You're so welcome.
Okay, I know this isn't the most fun topic. However, it's really important. We can't maintain our program without the correct documentation. And so all of this is, yes, it's not the most fun to go over, but it's very important. So let me start off by, so we have to report data to a registry called Get With The Guidelines in association with the American Heart, American Stroke Association. We also report these numbers to the Joint Commission. So as you can see, we did get, so basically the awards recognize hospitals that demonstrate at least 85% compliance with 7 of our core measures. And so that includes like TPA times, what else does it include? And includes early antithrombotics, meaning giving an antithrombotic by end of day 2, VTE prophylaxis, antithrombotics for discharge, anticoagulation for AFib, flutter, smoking cessation, all these measures basically. So if we meet them 85% of the time, we get gold. So we have gold here. In addition, we can get gold plus. There's another set of, the reason we have gold plus is because on some additional measures, we reached 75% of the percentage of, it has to be like 12 or 24 months in a row. So again, so we do have the highest in terms of gold plus here, but for stroke specifically, they have this stroke phase 3 recognition levels. And right now we have the stroke honor roll elite. That's this one right here. Can you guys see my mouse hovering? Okay, so that means 85% of the time we get TPA into our patients at least, below 60 minutes. We do, our goal though is to get honor roll elite plus, which means our door to needle times would be within 45 minutes for at least 75% of the time, and door to needle within 30 minutes for at least 50% of the time. So we're not hitting this. We're not hitting our goals. There's lots of reasons for that. But again, so we did get stroke honor roll elite. So that's not to undermine that, but I know that we can hit the honor roll elite plus. In addition, there's also a diabetes honor roll. So we also enter data for our stroke patients that have diabetes, or when they come to the hospital and they're diagnosed with a stroke and there is diabetes and the patient has diabetes, there's a whole bunch of extra education and things that we have to do for that. So we did get our diabetes honor roll. So again, just because, you know, I just want you guys to understand, like, you know, that there's a lot going on behind the scenes. So what is a comprehensive stroke center, and why is it important that we maintain our certification? Well, that is the most demanding stroke certification you can get, okay? It's for the most complex stroke cases. We have to hit certain numbers. These are our current volumes, so you have to have at least 30 mechanical thrombectomies every 2 years, 50 TPAs over 2 years. We gave like almost 100 patients TPA just last year alone. And for thrombectomies, we did 87 last year. So obviously we're hitting our goals there. We also have to have advanced imaging. We have to have post-hospital care coordination. Megan has follow-up phone calls she has to do. And we also have to do follow-up phone calls for all our TPA and thrombectomy cases and coiling cases. On top of that, we're supposed to have a dedicated neuro-intensive care beds with a neurointensivist 24 hours, IR capability, and active research going on. We have about 7 studies going on at one time. I just wanted you guys to see this. This is a report from LA County EMS. So these are all hospitals that are stroke receiving centers in LA County. And I wanted you to see that by number, our hospital, which is LBM here, we have to, for HIPAA reasons, block out everything else, but you can see that we have the highest number of stroke diagnosis in LA County. So our program's huge. And it just goes to show you, you know, I mean, we have 47 more than, and we're talking Cedars, UCLA, all the LA County hospitals in the area are included in this list. And we have the most, okay? So I think that's important to know as well. So what are the primary, we have, because we are a comprehensive stroke center, we have primary core measures and we have comprehensive core measures. Now, these are the primary core measures. We really should be hitting 100% on all of these every single month. We're gonna go over all these and we're gonna take each one, you know, each one individually, but these are the primary stroke measures. As a comprehensive stroke measure, core measure, this is the other core measures. And again, we have to report percentages for each of these. There's 18 total that we have to present. So you can see these are comprehensive stroke measures. We talk about subarachnoid hemorrhage and ICH scores, reversal agents for bleeds, hemorrhagic transformation, nimodipine, and a ton of things for our thrombectomy patients in terms of time-sensitive marks like door to groins and revascularization times and all sorts of things that we have to report, because if we're not meeting these goals, then we're not giving good patient care. And we shouldn't be taking care of these patients because we don't have the capability to. In addition to our primary and core stroke measures, we also have quality measures. These are measures that we report as well. And some of that gold plus gold stuff that we talked about include these. So we have intensive statin therapy, LDL documented, dysphagia screens, smoking cessation, and NIH reported. We're going to go through these too. These are our numbers and percentages for primary stroke core measures in all of 2021. I didn't include December because we don't have that report yet. You can see for VTE, we're doing great. Antithrombotics on DC, you know, yellow is okay, but we don't want to see any red, okay? If we have anticoagulation for atrial fibrillation, if we have 4 patients discharged that were in AFib and not in anticoagulation, and one of them, because their meds weren't reconciled, that goes down 80% automatically. So it is based on the N number. You can see if we don't have an explanation for TPA delay, we'll get a ding on that. And we have to report all of these numbers. You can see stroke education. This is during COVID months where our we had the charting where we didn't have to do education, but we still have to report these numbers to the Joint Commission and to American Heart, American Stroke. And you can see we're still struggling here. So I am going to go over how to document stroke education. Rehab, we do pretty well. Our dysphagia screen, we're still hurting. We're working with ED and they're coming out with some order. I don't know, Angie can explain it, but we're trying everything we can to increase this number. LDL documented, intensive statin, and I'll go over all this. So those are our primary core. And this is why using our order sets are extremely important, because our core measures are all the points in our ischemic stroke order sets and our other order sets. The core measures are all, you know, in there, so we don't miss things. These are our comprehensive stroke measures. I'm only going to put 8. We're only looking at these. I'm not going to show you all the other ones, but you can see just NIHSS for acute ischemic strokes. We should be getting 100% of these. We don't hit that. Severity scores. You can see if we don't have a stroke nurse on, what happens most of the time. It depends what physicians are on. We do education for our physicians as well. So this does not fall on nursing, you know, all by yourself. I report these at meetings that we have with the physicians as well. So it's a team effort. You can see, again, we're not hitting our, you know, our goals. Procoagulants, we do pretty well with that. Our hemorrhagic transformations, we go over every single one. And so to see if they're true hemorrhagic transformations, but you can see that we do have that complication. Nimodipine, you would think we would get 100% for all our subarachnoid hemorrhages, but we still don't, especially if the order set's not used. And you can see that, you know, I know Megan talked about revascularization scores in our thrombectomy patients, and to hit a 2B or higher, that's good revascularization. That's our goal. So we have to report all that. How many patients that we do thrombectomies on actually reach a revascularization score of 2B or higher. So you can see we're not, you know, we have a lot of work to do still. Not to say we don't do good stuff. Our patient outcomes are great, so I don't want to lose sight of that, but this is documentation purposes, you know, for our documentation purposes. Okay, so the first thing you have to know, because a lot of these core measures are time sensitive, is you have to know when the patient got here, because we give a lot of, you saw the wording, give by hospital day 2, give by second midnight on, you know, whatever it is. So you have to know when the patient got here. Okay, so there's 3 ways you can look at that. If the patient came in through the ED, you have to access the ED arrival time. You can see here, you have to find ED timed events. You can get ED timed events through the nurse index that I know you guys have in your flow sheets. And you just go to ED timed events, and the time the patient came is right here. So this is the timestamp that everything's going to be based on, including if the patient gets interventions such as TPA and thrombectomy. This is the time that we use. If the patient was a direct admission, we have to access ADT events. This goes for patients that, you know, came in for an elective surgery, like an orthopedic surgery, for example, or a cardiac surgery, and didn't come through the ED. If there's a code stroke called on those, we have to know when the patient got here, but it's really important to know, you know, when the code stroke was called. So for all of our code stroke, inpatient code stroke, if there is a code stroke inpatient, the arrival time and date is thought to be the time the code stroke was called. Okay, so everything is timed based on that time. Does that make sense to everybody? These are our order sets. So these are really, 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 really important. Anybody can put these in terms of hospitalists. It doesn't just need to be the neurologists, the neurosurgeons, or the IR physicians, okay? These are meant for hospitalists. These are meant for ED physicians, and also for our ICU teams, our residents. So just to make you guys aware as the nurses that, you know, if you don't see an order set being used on a patient, it's something to tell the physician about. You can see that we have one strictly for the ED, we have one for our bleeds, we have one for if you have an allergic reaction to TPA, which I know Megan talked about as a complication. We have a post-TPA hemorrhage order set. We have a post-TPA thrombectomy order set. and TPA treatment order set. Some of the ones, the newer ones, the subarachnoid hemorrhage, some of the just so you guys know, we do track this. And so, just to be aware, and we also have delayed cerebral ischemia with different, because all the strokes have different blood pressure parameters and different things that need to be dealt with and addressed. So that's why the order sets are really, really important. Oops. Okay, let's start with VTE. I know that this is supposed to be pretty basic, but a couple things you might not realize is that if a patient, these are fallouts that we see. So I'm going to explain, why we would have fallouts. You can see with the VTE prophylaxis, now that they don't have an option in Epic to have the sequentials off as a choice anymore, we're not really seeing a problem with this anymore. However, I just want to emphasize that antiplatelet drugs do not count. If the patient's on aspirin, that's not considered VTE prophylaxis. Compression stockings do not count. They have to be sequentials, okay? The only thing that nursing can say that will count is that the patient refused the sequentials. A low VT risk order is acceptable. So, but if there is an order for medium to high risk, there has to be VTE on the patient. And if not, there has to be a doctor's order to say why. Patients getting TPA, just because they have TPA in their system, does not count for VTE prophylaxis. We have seen that. We've had nurses document that the patient got TPA, so they don't need sequentials. Again, this is something VTE, this is a complication for stroke, and that's why all these things we have to report, because it's best patient care for this patient population. And obviously, this is where you find it, and you want to make sure that when you hover over this again, that it has the right thing on there. But I said, once they took away the sequentials off, we're not really seeing this as a problem. But it has to be documented by end of hospital day 2. So it doesn't matter what time the patient came in day 1, it has to be documented in the flow sheet by end of day 2. So by the second midnight, it has to be documented. Discharge on antithrombotic therapy. A big problem we see with this is that hospitalists or whoever's discharging the patient does not reconcile their meds on discharge. Meds have to be reconciled on discharge for everything, for SNFs, for LTACs. The only time I think they don't reconcile the meds is when the patient goes to our inpatient rehab, because we can see with the patient what they were discharged on. But so for all the rest, antithrombotic therapy includes both anticoagulants and antiplatelet drugs. These are some examples, and you can see here when we abstract this data from the chart, we go to the medication list at discharge. So if it's not reconciled, we're not going to see any meds here, and there's no proof that the patient was sent home on these meds. So we can't, unless the meds are reconciled to discharge, we have to assume that they weren't. So that's very important for discharge. Stroke measure 3, anticoagulation therapy for AFib, A-flutter. If the patient is in AFib, which happens a lot with our stroke patients, they come and they're in AFib and they didn't know it. Or if they have a history of AFib, or they have PAF and they're currently not in AFib, but they may be in a week or 2. It's important, if it is documented anywhere in the chart that the patient has PAF, it has to be addressed. Okay. Why is the patient, and these are some examples, these are our newer oral anticoagulants, such as Xarelto and Eliquis. These are the ones you're most going to commonly see. Some of our patients still go on Coumadin for insurance reasons or for other reasons, or it has to be a full dose Lovenox. We've seen that where a patient was sent home on a sub-Q Lovenox, and maybe the nurse thought that counted, but it doesn't. It has to be full dose for anticoagulation purposes. And you can see, for example, this is an actual one of our patients on their hospital list. The patient had AFib. The patient had AFib during the admission, and luckily they were discharged on Eliquis 5 milligrams. So if it's not addressed, where it's going to be a follow-up, and the physician has to write a reason why we didn't get the anticoagulation. A lot of times our stroke patients, they do have AFib, but we cannot start them on anticoagulation because of their strokes. They're too big of a bleeding risk for whatever reason. That has to be documented in the doctor's chart and the doctor's note. Antithrombotic therapy by end of hospital day 2. Again, we still have fallouts on this. And these are things that count. Aspirin and Plavix are going to be the ones you see most of the time and the ones that are used the most. So you can see this is a linked order. So if the order set's not used, this linked order won't come. And what's important about the linked order is that if the patient has to be NPO because they fail to swallow a valve, the rectal aspirin is right here. Surprisingly, we still have a lot of patients where the nurse has the option to give the rectal aspirin, but for whatever reason doesn't. Because we've had comments like awaiting swallow eval. Okay, well, that's great, but now, you know, we have 6 hours before end of day 2, and they still haven't gotten their aspirin. And it's not just for documentation reasons. These meds are given for a reason. You know, we're trying to prevent strokes from reoccurring. So it's very important that these patients get their meds in the time frame that they need them. So when the order set is used, this link will come up. So you have an option. If the and you know, there's other antithrombotics that are available in the order set. So if you see one and there's not a rectal one, like say it's Plavix, we might need to put an NG tube down and get that into the patient. We can't just hold antithrombotics because of, you know, NPO, because a lot of our patients are going to be NPO and require swallow eval. So we need to figure out a way to get these meds in the patient in a timely manner, you know, before their formal evals are done. Discharge on statin. Okay, once this goes for ischemic stroke patients, okay? This is not a measure for our hemorrhagic patients, and that's why it says ischemic here. If we look at LDLs in the stroke world, so once a patient's LDL is 70 or more, we have to discharge them on a statin. So, so that's a very important thing, and that's why we need the lipid panel as part of our admission process for the stroke patients. It has to, the LDL is one of our quality measures, and it has to be resulted within 48 hours of admission. And the reason is because we need to know what the LDL is. So 130, that's high, that's above 69. So obviously this person's going to have to be discharged on a statin. Most just for most of our ischemic stroke patients are going to be discharged on some type of statin. And you can see here, this LDL was 21. So that's very low. And that's because this patient was taking their at-home Lipitor. So, but this wouldn't, if this patient came in and wasn't on anything and LDL was 21, that would be an indication not to give, you know, a statin. However, there are sometimes LDL is still low and the patients still go home on statin therapy because it's what's best for the stroke patients. Stroke education. Okay, this is a tough one. So when we do stroke education, we have to, there's 5 key things that we need to speak to the patient/family caretaker about. It needs to be these 5 things. So activation of medical emergency system, calling 911, need for follow-up after discharge. There has to be a discharge appointment for the patient following discharge for stroke. Medications, why are they on the meds that they are, and how, you know, why is it important that they're on them? Risk factors for stroke. This goes a step further for our facility because we have to speak specifically to the individualized patient's risk factors. So all of this has to be educated to. And warning signs, basically, what are the stroke symptoms? We see this a lot of missed. What we see in terms of fallouts is that the care plan's added, but not documented to. And they'll resolve it without any documentation to it. So we just need to make sure the care plan 1 is added. So there's only 2 care plans for stroke. There's ischemic and there's hemorrhagic. Unfortunately, in our care plan, when they made this, when they did the EPIC upgrade, they changed this without telling us. And it's hard to get changed because it's you know, it's through all the hospital systems. It's not just us. So 5 of them aren't even all here. So you can see when you open up the stroke ischemic care plan, we have 4 of these here. So we have the stroke, you have to make sure at least these 4 are checked, okay? So you have to check signs and symptoms. You can do the modifiable risk factors and check the ones that are specific to your patient. You can also, there's provider follow-up, which is under self-management, and then when to seek medical attention for unresolved or worsening symptoms. So what we found that we wanted to create a smart phrase that we can put into the care plan in order to address these 5 things. It only has to be done once during the whole admission. So you're not doing it every single, you don't have to add this every single time you're documenting to the care plan. You can update it as needed. So what we did is all of you guys all you have to do is ask me or Maria or your educators have access to giving you this smart phrase. And what you do is once you open up the education, you click on comments right here, and this will open up this education note. And in the white body text, you're just going to type .edu stroke, and you're going to click on it, and it's going to populate the 5 education points. Okay. And then you can personalize them. And as long as this is in the patient's education, this will count. And it is good for patients to know, like I said, 80% of strokes are preventable. So this is very important education for our patients. And a lot of times when patients come in here, they're so shocked and they're overwhelmed by everything that we're teaching them. So just reinforcing the teaching every day, and Megan goes and does education as well. And in her discharge note, she'll do a discharge note with their personalized risk factor. I mean, this is very important. If you have a patient that's being discharged, and again, Megan's only here 5 days a week. She's not here on the weekends. So if we have a patient that gets admitted for a stroke on a Friday and leaves a Sunday, we have additional smart phrases for discharge instructions. So these are also smart phrases that have to be assigned to you from your educator. And basically what you do is you open up the discharge doc, you click on discharge instructions here, and this will open. And then in the white body text again, you just do this. We're doing an example of the stroke ischemic one. So you just put this in the text of the white body. This will populate, you click on it, and then this is what comes to fruition once you do that. And again, as you scroll down, there are places that you can put the individual risk factors, labs, all that. And Megan has her own discharge note that she does. But again, if she can't get to the patient because we're not here every day and at night, this can definitely be missed. Okay. Asked us for rehab. If you use the order set again, all of this is taken care of. One of these has to see the patient, okay? If for some reason the physician feels like the patient doesn't need the rehab for whatever reason, they have to be specific in their note. Patient returned to prior level of function, rehab not indicated at this time, okay? If the patient's not amendable to therapy because they're comatose or they can't do it or they can't participate, whatever the reason, the rehabs, they all write their notes and say they're unable to, see the patient at this time because of their mental status or whatever it is. So the rehab, don't cancel the evaluation, even if it's not appropriate for the patient. And this is what you will see if our order set is used. So you can see all of the different therapies are included. And again, most of our patients do need therapy in one way or another. This is a huge part of their rehabilitation process. Any questions about, I can't see anyone, so if anybody has questions, someone tell me, for the primary stroke measures. And then I will go on to the comprehensive. Okay, it doesn't seem like anybody has questions, right?
There's nothing in the chat room either.
Okay.
So
I don't blame you. Okay. So for comprehensive, our first one is the NIHSS has to be performed for ischemic stroke patients, either before they get treatment in terms of an intervention like TPA or thrombectomy, or if the patient's not getting any treatment and there's nothing we can do, we still have to chart the NIH within 12 hours of the patient's arrival. This is important because we need a baseline NIH. We need a baseline NIH for our thrombectomy and TPA patients, because if they have a bleed, we're not going to know how many points they got worse. There's very specific points, like the NIH increases by 4, we need to know. if the patient gets worse. So NIH is very important. This should be done in the ED or by a physician, okay? Sometimes we see fallouts because the patient arrived in the middle of the night, the ED physician didn't do it for whatever reason. They all are NIH certified. We don't have a stroke nurse, and the neuro initial note, I mean, if it's in the neurology note, then that counts. Or if we have a delay in diagnosis. I mean, there are a lot of reasons, but basically it's very important to make sure that the patient has a baseline NIH and it is time sensitive and it has to be before intervention. So yes, you have to add the NIH stroke scale, and you have to make sure that you add every single part of the stroke scale. We have a lot of, another reason we have fallouts is because the nurse maybe skipped a couple because the patient's comatose or something. And then a total score does not populate. There is a way to perform NIH on comatose and intubated patients. And those, we have resources on our stroke department website, which I will show you at the end. But again, it's very important to score every single part of the NIHSS to get a total score, okay? And you can see here, for an example, this patient got TPA at 1546, and this was documented at 1457. I mean, this is a big difference. I would like to see another NIH a couple minutes before the TPA is given, so you have a good baseline before the patient gets TPA. But again, it's very important that you add the NIH stroke cell and you perform it. It should be done in the ED. It should be done before intervention. You know, it just needs to be done for stroke patients. Okay. Severity scores for ICH and SAH. These are good tools for prognostication, like Megan was saying, and it's important that we do this. This is also time sensitive. It has to be done within 6 hours of the patient's arrival to the ED, or documented before surgical intervention. We have seen fallouts because of so many reasons, but just be very careful of, you can always start your note if you don't have like volumes, for example. Here, let me show you. So this is the ICH score. I know Megan went over it a little bit in her lecture, and you can see that this patient, this is one of our patients. This is their picture of their ICH, and this patient had an ICH score of 4. And you can see that this patient has a 97% chance of mortality within 30 days. So this was documented within the 6 hours. This is from a neurologist's note. And then you can see that this is the subarachnoid hemorrhage. And this is the Hunt and Hess scale. This is an actual, one of our patients' subarachnoid hemorrhage, which was a Hunt and Hess of 5. And you can see this is in the neurosurgeon's note that there was a Hunt and Hess grade 5 bleed. We don't, Fisher score usually comes along with it, but it's not considered a severity score for our purposes for core measures. But it is important to know because it can predict vasospasm and is based on the amount of blood on the scale. But again, I just wanted you guys to be aware, and not having our stroke nurses for this has really hurt us because we don't have a point person to go to those initial strokes. And again, we really do a lot of education with our neurosurgeons, but you know, some of them have been here for a long time, and it's hard to get them to do new things that they're not used to. And Megan tries to help too when she catches that. I try to help, but again, we don't always get them in time. Procoagulant reversal agent initiation for intracerebral hemorrhage. So if the patient comes in with a bleed and the INR is greater than 1.4, we have to intervene regardless, okay? However, if there's evidence that the patient was taking an anticoagulant such as Coumadin, Xarelto, Eliquis, whatever it is, we have to provide a reversal agent within a timely manner. So you can see here, this is an actual, this is one of our patients that was on Coumadin and had a bleed. And so we had to give the patient Kcentra, which is a reversal agent. So this is we have order sets for these things. So you can see this is the one for Indexa, and then you can see this is the one for Kcentra. And our doctors and ER physicians are very good about doing this when a patient comes in and they do have. Just so you know, FFP is not the greatest reversal agent. And really, we have better medications to really reverse these meds. And so you'll see some old school doctors still do it, but really it is not the best thing for the patient to reverse bleeding in the brain. It just fluid overloads them and it doesn't really help, it doesn't lower the INR fast enough in order to like really help. Okay, hemorrhagic transformation. There are a lot of reasons why a patient's NIH baseline would increase four points or more after TPA or thrombectomy. It could be because they're intubated and they're on sedation. It could be because they have bleeding. It could be for a lot of things. But so we have to look at all these cases individually and, is this a true hemorrhagic transformation? But according to the core measure, a true symptomatic hemorrhage is a patient that had a clinical deterioration of 4 or more points, an increase of 4 or more on the NIH, and there was a finding obviously on the CAT scan. And it has to be within 36 hours of the treatment, whether it be TPA or thrombectomy. This is not like hemorrhagic transformation for a patient that didn't get intervention. I mean, a lot of our patients have hemorrhagic convergence of their strokes and their stroke beds. That's not something we did to intervene, So again, it has to be specific to TPA or to thrombectomy. It has to be specific to our interventions. This is an example. This is an actual patient we had in December that had a hemorrhagic transformation. You can see this was his baseline CT. And this is what happened this is what happened after he received TPA. He was still in the ER when this happened, unfortunately. And I think, so you can see here that he was alert. NIH is still high at 25, but you can see a little bit later, I think this was 15 minutes after, 20 minutes after, he became completely not alert and comatose. So he went up 4, and the ER nurse was smart enough to get the ED physician to, order a CAT scan, and it came back as this. And so obviously you can see this is a true hemorrhagic conversion, and one that we report to our higher people. And it's good for us to know what our hemorrhagic, because obviously if we're having many hemorrhagic transformations with our interventions, again, we should not be doing this. This is not something that we're good at if we're having a lot of hemorrhagic transformations, and we don't have a high hemorrhagic transformation rate, but it's still something that we have to look at. Okay, nimodipine treatment. This has to be given within 24 hours of admission of a subarachnoid hemorrhage. Now, if the order set is not used, or if the neurosurgeon or someone doesn't order this in a timely manner, we see fallouts on this. We also see fallouts because the patient can't swallow. This is a reason why a patient would need, an NG tube to give it. What's tricky with the nimodipine is if we have a subarachnoid hemorrhage of a 1 or 2, and the patient seems totally fine because maybe they just have a headache, and they're sensitive to sunlight or whatever, but they don't have any focal deficits, they seem fine and they really shouldn't have swallowing problems. And so a swallow eval will not be performed on these patients. But what you have to remember is that a swallow eval has to be done on these patients, even if you think, they're capable of swallowing. So we get swallow evaluation fallouts for nimodipine a lot, because if like I said, if this Hunt and Hess is low and the patient seems okay and they're able, they have no focal deficits, it's something that could be missed. So it's important that a swallow eval is done before this and in a timely manner. If it's not, and the patient is unable to swallow, or the swallow eval cannot be done till the next day, that we need to insert an NG tube, because our patients, this shows that patients that take this have better outcomes by getting this calcium channel blocker. So it is still part of our practice and recommended. And you can see here the patient arrived, just an example, this is again I used all of our own patients in this lecture, and you can see that this patient was a Hunt and Hess and came in on 1:30 at 11:31, and luckily this was given that same day at 13:48. Just so you know, if your nimodipine is dropping the blood pressure of the patient too much, it can be divided doses. So instead of 60 Q4, you can order nimodipine 30 milligrams Q2, and that won't drop the blood pressure as much. Because again, once the aneurysm is secured, you want permissive hypertension. And so if that's dropping the blood pressure too low, you can give it in divided doses. Okay, Now we're gonna get into our stroke quality measures. You can see that the LDL documented is part of the lipid panel, which is in our order set, and it has to be resulted within 48 hours. So if the order set's not used, this doesn't get done, unfortunately. And it's important because we need to know what statin needs to be prescribed for the patient. So it's important. The only time we don't need to do an LDL is say the patient was just here a week before for the same thing. Maybe they had a TIA or another stroke, and there's already LDL that is resulted within 30 days, and that counts. We don't necessarily need to do a new one, but that would be the only time that would count. Okay, intensive statin. This is a tricky one. Our doctors, I feel like, have gotten a lot better with this measure, but these are the doses for intensive statins, okay? And it has shown that by giving intensive statin, we can, greatly reduce the LDL, which just helps our patients even more. So now what we want to do is we want to discharge our patients on intensive statins. So we get a lot of fallouts and these are, so it has to be Lipitor 40 or 80. This is what counts as intensive statins, I should say. Lipitor 40 or 80, Crestor 20 or 40, Zocor 80, or this Vytorin 1080. Okay, these are what are considered the intensive statins. Now, if your patient's LDL is 131 and you see that your patient's being discharged on Lipitor 20, okay, maybe that's because that was the home dose they were taking and the hospitalist just reinstated all their home meds. It's important to look at the neurology notes because that's where you're going to see what statin the patient should have. And again, we tell the hospitalist this, but it takes a village to get all this information out, especially for nurses that aren't taking care of these patients day in and day out. So it's very important to question, why is this patient being discharged not on an intensive statin? So it's not only do they have to be discharged on a statin, they really should be discharged on an intensive statin. And if they're not being discharged on an intensive statin, we have to know why. And it has to be documented by a physician or a practitioner of some sort. Again, I know this shouldn't fall on the nurses, but I just want you guys to be aware that these are things that our stroke patients need, and it's best practice, especially if your patient has really bad atherosclerotic disease and they're on maximal medical management for stroke. Intensive statins are really important for that patient population. And you can see here, this patient, you can see the LDL was 21 and they were discharged with Lipitor 20. That's fine. The LDL is low. Okay, we're not going to question that. But here for an LDL of 130, I would expect the patient to be discharged on an intensive statin. And you can see here that the atorvastatin calcium of 40, which is an intensive statin dose, is appropriate and will count. Okay, dysphagia screen, guys. Okay, I know fallouts we see for those, if the patient's a direct admit, say they're a transfer and they come right to the ICU from an outside facility. Sometimes the nurses forget to do a full swallow eval, especially if the patient's talking and all of that. In the ED, we do so much education. We follow up on every single dysphagia of fallout. But again, it's still, you have how many nurses working the ED and bunch of travelers and, everything's different in different hospitals. So we just need to make sure that we're documenting the full swallow evaluation. And again, you can't miss any part of this or it will not count, just like the NIH. You have to put every single part. This is how, and the reason is because this is our policy. You can't proceed on to the next until you finish the previous. Make sure it's very time sensitive. Fallouts for this, as we see, is in the ED a lot of times, if the patient, it's not thought to be a stroke yet, because they have a symptom that's not, typical, say they're just dizzy or have ataxia and it's a posterior circulation stroke, but they're given Midodrine for dizziness, not Midodrine, what's the other one? The dizzy med, I forget it. But anyway, so it's just important to do a swallow. If you are ruling out stroke or getting a head CAT scan because someone thinks it's a stroke, the nursing eval should be done. What can be helpful if you're getting a patient from the ED and you notice that they got meds in the ED, but there's no swallow evaluation, please ask the nurse to retroactively put in the swallow evaluation with the appropriate time. That is before the time they gave the med. We see a lot of that. We see a lot of, I gave the aspirin at 1831 and I documented the swallow eval at 1832. So just be very aware of the times for this. So basically for our stroke patients, this really goes for all our high risk population, but that includes stroke. If a patient passes the swallow screen, they're still not cleared for a regular diet, okay? All of our stroke patients have to be assessed by dysphagia, okay? So if the patient passes the swallow screen, really what the nurse should only be giving the patient is oral medications. And they can call the physician to request a full liquid diet order. That is as high as you're able to go. In order to advance the consistency of the diet to say a regular diet, they need the dysphagia team to evaluate, okay? So I know this is not ideal because a lot of speech therapists can't see the patient until the next day, etc. But until the dysphagia team is able to evaluate the patient and determine that they're able to tolerate a full diet, a regular diet, the only diet that they can have is a full liquid diet. Okay, this is something that's new in the dysphagia policy. And it was education that was put out. I don't remember how long ago, but you cannot advance the diet past the full liquid order. And what's a full liquid diet? This is what includes consistent foods which are liquid at room temperature, like pudding, soup, tea, anything, any liquid that you don't have to see through it, so it's not clear, but this is the extent of what they really should get besides medications. If the patient fails the nursing swallow screen, obviously you are not going to give them anything by mouth until a formal dysphagia screen is completed, and that's why we have the rectal aspirin if needed or NG tubes. Okay, NIH reported, this is again just another baseline NIH, just really when a patient comes in and it's thought to be stroke, there really should be a baseline NIH in the documented. And it should be, in the first arrival notes from the ED or in the documentation in the flow sheet. Smoking cessation, this is tricky because even if the patient just quit, it has to be within, but if they quit within the year, they still need smoking cessation education. So patients who have smoked at least one cigarette within the past year need to be educated on smoking cessation. If there is a Nicoderm patch in the MAR, that counts, okay? But really where it's best to document it is in the care plan. And we also, just so you know, we have, Megan, we have these in our office. They're basically a smoking flyer. It's called Free From Smoking. And it's basically the hospital system has these smoking cessation classes and they're offered on Zoom. And, this is a resource that we can give our patients. Last thing is just the stroke depression screen. This is not one of our core measures, but it's very important for the stroke patient because a lot of our stroke patients do get depressed and aren't able to participate in therapy and need social work involved. Having a stroke is very depressing, especially depending on where it is in the brain. It can affect our serotonin levels and certain things. A lot of patients don't have the stamina to do therapy, or they're just depressed and can't do it because they're so down. So it's important to do a stroke depression screen as much as you can before the patient gets discharged. If we have to put, sometimes we have to put our patients on, neurotransmitter, what is it, like serotonin, SSRIs, yeah, in order to, get the patient to be able to participate in therapies. And those meds take weeks to start working. So the sooner we do these, the better it is for the patients. And this is something that Megan does look at for all of our stroke patients. And if we see that there is, that the stroke patient is affected by their stroke, social work can get involved. And it really is just another resource for the stroke patient. You know, because it has changed their lives. Okay, for resources, just so you know, we have a stroke department website, and it's found under Stroke Center and under all departments. We have Med-Surg ICU stroke checklists in order to also, you know, all of our core measures are on there. They're good tools to use. We have NIH resources. We have NIH in plain English, was just the wording for the NIH sections are just a little bit easier to understand and not so technical. So it can help somebody that's not experienced in NIH maybe do an exam a little bit better with easier language. We also have resources to do NIHs in the comatose and intubated patients. We also have TPA and thrombectomy charting tools. If you have a patient that is status post TPA or thrombectomy and you're a PACU nurse, or you're in the ICU and you don't know where to find this, all of these can be found on our stroke department website. And also our educational opportunities. We have these classes, we have SDRN coming up, and that flyer is posted on our website. Okay, I'm quickly gonna, I got a fake patient, so we could go through a chart. I know that doesn't sound fun for everybody, but okay, let me just get in here really quickly. Let me start sharing. Let me stop sharing. Hold on a second. Could everyone see this? Okay. Can everyone see? Yes. Okay. So let me get in here. I just want to kind of show you where we document stuff and where we abstract from so you guys can see. So I had Epic make me a fake patient so I can show you where to find all this stuff. Does anybody have any questions to this point? No? Okay. Okay, so this is, so when we go in abstract data, or I look at a patient chart, or Megan looks at a patient's chart, Nevaeh looks at a patient's chart, I'm gonna show you where we find all this stuff. So first of all, I can see here that our order sets were put in. Okay, so you can see here, I know that our order sets are put in. First, I want to find out, when did the patient get here? So I'm going to go to the nurse index, and I'm going to go to ED timed events here. And this is my door time. So you can see here that, remember, all these times are relative. This is a fake patient's chart, but you can see that this patient came in at 7 a.m. in the morning on 1/8. And so that's what I'm going to time all of my stuff from. So if we go through the VTE list, so I should have an order in the order set for VTE. So I'm going to go to my flow sheets. I'm going to make sure that the nurse documented the VTE prophylaxis before the second day. So I'm going to go into peripheral neurovascular. I'm going to see here the VTE, you know, the VTEs here and the sequentials are here. Okay. And it does say on. So again, that sequential compression devices off is not even an option anymore. Remember, compression stockings do not count. I think foot pump devices do. They do count. But you can also put the patient refused. So if you put the compression stocking on, but there's no VTE low risk order, then it's going to be a fallout. So please make sure that if the patient's walking, talking, you don't feel like they need sequentials, there's a low VTE risk. Okay, so there we go. Discharge on antithrombotic therapy. So I'm gonna go to the med discharge list. So I look at this by going into the patient's encounter. And this patient hasn't been discharged yet, but let's pretend that this is the meds have been reconciled and that this is their medication list at discharge. You can see here that the patient's being discharged on aspirin. So we're good there. That meets that measure. Anticoagulation therapy for atrial fib. So I'm going to go to the history. I'm going to see, does this patient have a history of AFib? You can see that he has type 2 diabetes, hypertension, AFib. Okay. If it was mentioned in the note, if it was mentioned somewhere in the chart that there's a history of PAF by some doctor, then it has to be addressed. So again, I'm going to make sure that the patient is on some type of Eliquis or Xarelto, or if not, there should be a note here. So now I see that there's not. Okay. Is it because a patient had a huge stroke and their risk of bleeding is too high? Is it because they have microhemorrhages on their post TPA CT? I don't know, but it has to be addressed in the notes. Okay, so that's something that potentially could be a fallout if you don't have a physician or a practitioner reason why they're not on it. Thrombolytic therapy. Okay, this patient got TPA. So I'm gonna look and see when the patient got it and make sure it was within 60 minutes. And if not, what was the delay? So you can see the alteplase is here. Okay, it's a linked order. It comes with the bolus and the infusion behind it. So I can see that this was given at 7:26. That's obviously 26 minutes after arrival time. Remember, the patient came in at 7. So that's within 30 minutes. So there must have been a stroke nurse on this day. No, I'm just kidding. The ED can also give this, but they're just, that's not their role. They don't do this all the time. So, it's hard. And then we hang the bolus right after. It should be given within 5 minutes after the TPA bolus. Okay. So now that we gave thrombolytic therapy, I'm going to have to find an NIH before the TPA. I'm going to need vital signs and all of that stuff. Okay. Antithrombotic therapy by day 2. Now, it's tricky for TPA patients because we can't give the antithrombotic therapy until the post-CT is done 24 hours post the TPA. So you can see here that there is aspirin, and it looks like this was given, which it's just a play patient, okay? So he couldn't go back and redo this. So what I wanted to show that this was given the next day at like 12:30, okay? It still counts as a fallout if the patient does not get their aspirin by end of day 2. So, but it also depends on timing. The physician can say the patient got TPA at 11:30 the night before, and so the post-op CT is not going to be done till 11:30 the next night. If the doctor puts in a waiting CT before starting aspirin, then that will count. But the patients still need their aspirin after the post-op CT is negative. So just be aware that the aspirin still needs to be given as long as the post-op post-TPA CT is negative for blood, and because it will be a fallout. So that's something to be, and again, there's a linked order in case the patient hasn't had their swallowing eval yet. Discharge on statin medication. Let's see what the results were for the LDL. So I know the order set was used. So I'm hoping that the lipid panel's here, and you can see here it is. Can everybody see that here? You can see the LDL is 131. So now I'm expecting the patient to be discharged not only on a statin, but I'm also looking for an intensive statin. So I'm going to go back to the hold on, let me go chart review. I'm going to go back to my chart review in the hospital encounter. I'm going to look into the medication list at discharge. And yes, the patient has Lipitor at 40. So we met that measure. Again, I won't get this if the meds were not reconciled at discharge. Okay, so that's an important piece to do before the patient gets discharged. And then stroke education, let's see. First, I have to see if the care plan was added, which it was. So we have the stroke ischemic, you know that you can add the care plans here. And then when we go into the education, I'm going to document to it. So I'm going to chart on, I want to do the signs and symptoms. The patient has AFib, they have high blood pressure, high cholesterol. I don't think they're a current smoker, but if they were, I would check this here. I'm going to tell the patient that they need to call 911 if they're home and they need, they have stroke symptoms and what those are. And then I'm going to, and now I need the follow-up, the provider follow-up right here. Okay. So, but I also want to put in the comments, you know, our 5 key things. So I'm going to click it here. So I just opened the comment box here. Did everyone see that? Okay. And then I'm going to click in the, I'm going to click here and I'm going to type .edu stroke. Okay. It's not working for whatever reason, but if it was, so I'll have to tell Epic about that. But once I populate it here, my choices will come out and I can do it. Okay. And then all those 5 things, like I showed you in the PowerPoint, will populate here. You can edit them at any time. If you find another symptom, like say the patient ends up having diabetes, we can add it, okay? If there's a follow, so you can always edit them, but that's where you're gonna document and put the comment for the education. And then assess for rehab. I know that that was put in, so obviously this is a fake patient, so I would look for a note from one of the rehabs here. Even if they said the patient wasn't amendable for therapy for whatever reason, that would still count. So that's where I would look for it. Okay. For the comprehensive measures, we're going to look for an NIH. So I know I gave the TPA at 726. I need a documentation of an NIH before that. So I'm going to go to the NIH. It has to be added. If it's not there, you can go under neuro additional documentation, and it's going to be down here, the NIH stroke scale group, and you add it. Okay, it's already added here. I'm going to go back to when the patient got here, and you can see that they did do a baseline at 715, and it was 15. Okay, they gave the TPA at 726, and they're starting every 15 minutes on the 15-minute mark. So this is actually really good. So you can see that we do have a baseline. So that's before the TPA was given, and that will meet the CSTK1 measure. Okay. You can also see that just for documentation for TPA that we do it every 15 minutes and we want to keep going. Okay. This patient also went for thrombectomy. So wait, first I want to check my vitals. Okay. And you can see that they did a baseline vitals. And again, I want to do Q15-minute vitals after that TPA because, we have certain pressures that can't go above once we start the TPA. So this is documentation we're looking for all of our TPA and our thrombectomy patients. Okay, so we don't have a severity score that this patient's not a bleed, but if it was, I would look in the notes to find an ICH score. There's nowhere in the flow sheets that there's an ICH place to put an ICH score or a subarachnoid hemorrhage score, or a Hunt and Hess score, I'm sorry. If this was a bleed, I would also look at the MAR. I would look at the results, I'm sorry, to see what the anticoagulation was. And if it was a bleed, it's not above 1.4, so I wouldn't have to do a procoagulant. And also, but if the patient was on meds that, if the patient was on meds for their AFib, maybe they weren't taking it, and that's why the patient had a stroke, and that's why they got their TPA, because we still can give TPA if the patient hasn't taken one of their oral anticoagulants within 48 hours, okay? So I'm looking for all of that. If this patient got worse and had an increase of NIH of 4 or more, I would do a repeat CAT scan and see if there's hemorrhagic transformation. So this patient did go to IR as well. And you can see that there's a break in our documentation for vitals and things. Let me go to So in the transfer area here, just so whoever's auditing this chart or if Joint Commission looks at this chart, you want the chart to tell a story. So you can see that the patient got transferred to IR in a pretty good amount of time within the hour, because our door-to-groin time should be below 60 minutes. So they got to IR, and that's why I may have a lull in my TP, in my vital sign and NIH, documentation, but there's a reason why. Okay, once the patient's done with their thrombectomy, this will be added in the sheath puncture site. So I know I'm going off a little bit on the core measures, but I just want to remind nurses that are in the PACU, the ICU that get these patients where documentation for, the hematoma checks and the groin checks are and the pulses. So you can see here that the LDL, when a thrombectomy is performed, the puncture site will be here. And it could be a radial site. It could be a femoral site. It could be a lot of different sites. So whatever site it is, we have to document. If the site is normal, we can put WGL, but this is where you would document if there's a hematoma. This is where you could document the hematoma size, but make sure that the hematoma assessment is present, that we're doing the DPs and the PTs, pulses every 15 minutes as it's ordered in the post-thrombectomy order set, and also what the dressing looks like. Is there a little blood on it? Isn't normal? Because this is what the expectation is and what conforms to our order sets after each post-thrombectomy patient. So this is where you would find that. Okay, I think, are there any other questions of where I would look for something or where I would document something in a patient's chart? Was that helpful at all? Was it you know, just give me feedback. Is there anything that I could explain differently? Any questions? I don't think so.
Rebecca, did you get my note just now?
No.
Okay, when I was auditing the chart, a lot of times they're missing, like there's no vital signs or something, and I could tell from looking other places in the chart that they went to IR or MRI or something. That's when the NIHs weren't done, but very few people actually documented like 2 IR or 2 MRI or something. So could you just stress that in the other classes possibly?
Yes, of course. It's very
Okay.
important. Yes. And that's why this is so important, because exactly, we need a reason why those assessments weren't being done, an explainable reason why. So exactly, if the patient goes to MRI, if the patient goes to IR and is sitting on the table, and, you know, there has to be a reason why we're not doing the assessments, you know, right after the procedure's done, say they did get a thrombectomy or they're done with MRI, they're off the table, we need to be doing those assessments again. I mean, the patient basically can bleed right after reperfusion is achieved. So, you know, that's why it's so important to do those, but I will definitely stress that, and thanks for saying that, Amy.
Hey, Becca, I have a question too. Would it be possible to have Epic build like a flow sheet that's specific to like post TPA, post thrombectomy, like kind of how we have a CRRT flow sheet or hypothermia, and it has everything in one spot?
Yes. So we actually are working on one right now. Angie, me, Irene, Karen Walker, and some of the other in our team are coming up with a flow sheet to include not only vital signs and NIHs, but also the pulse checks if they go for thrombectomy. So there should be one flow sheet that will have everything you need for both post TPA and post thrombectomy and TR bands, if we can include that in there too. So we have come up with one, and maybe I think Irene looked at it already, but we are going to have that, just make sure that it includes everything you guys want, and we'll try to get that built as fast as possible. But yes, we are working on it.
Thank you.
Good idea, Emma. All right, everybody. If you would please go in and do your evaluation, that would be awesome. I really want you to give us some feedback. What was good, what wasn't good. This was the first time we did this. Should we never do it again? Whatever, just give us some positive. I'd love some positive feedback. Give us some honest feedback so that we know how to move forward. I want to see if this venue, if you will, was helpful. Well, I still have some of you. Taylor, I don't know. I don't have a name for you on my list. What's your last name? Do you have a last name, Taylor?
Yeah, Bonnie, Bonney.
Oh, I already got you there. You're right. That's confused me twice now. It's okay. I'm sorry. Gotcha. And Pam, are you from Saddleback or are you one of ours? Is she still on here?
She's from Saddleback.
She's a Saddleback person. Okay. I'm going to try and get some help to get this put into ULearn so that it's easy for everyone to track. And I will probably reach out to you guys to help me get this. We videotaped it, or it's recording. I should probably turn that off now. But we are going to record it and see if people want to come back and listen.
Angie, I had a couple of employees that I just been notified of that had wanted to attend today, but never got the link. I put that in my evaluation for you, but there were several Saddleback employees that did want to attend that never got the link.
Huh. The only set I had Rachel, Korn, and David. Are they either one of them?
No, not one of them.
Huh. Okay, because I don't have anybody else on my list, so I must have missed their email altogether.
Okay. I'll have them reassign a different day.
Yeah, tell them I'm really sorry. I tried to keep up with this every day and I'm sorry I missed anybody.
Yeah, not a worry, you got it, thank you.
Okay. Stop video. Stop recording, stop share. I hope everybody's done. And I'm gonna stop recording.